COVID.
Fine, actually. It's quite fine. We didn't
Quite
have
fine.
any problem. We had to do the test and all that, but that was fine.
শনিবারে তো পার্টিসিপেন্টই পাবা না।
ম্যাডাম সবাই তো জয়েন করে প্ল্যাটফর্ম দিয়ে, ওখানে তো অনেক থাকে, 500-600 করে থাকে, জুমে কম।
আজকে তো থাকবে।
কালকে দেখলাম 450 ফারজানার।
আপনার আব্বাসই তো পাঠাইছে। সেহরিন, আমি লিখছি তো তোমাদের ল্যাপারোস্কোপিতে জেন্ডার ডিসক্রিমিনেশন, মেয়ে লোক নাই। কেন শামিম কই? শামিম কই? শামিম শামিম বুঝছো 47।
কিভাবে সম্ভব এতদিন?
তার মানে কঠিন লোকের সাথে, বুঝছো আরো।
Arithmetic, yes. Amit sir, are you hearing me? দেখতে পাচ্ছি না মারুফ।
শুরু করে দিবেন না? ও আচ্ছা, অমিত কি আবার চলে গেল নাকি?
কোথায় গেল ডক্টর অমিত? রুমান,
ম্যাডাম,
হ্যাঁ ঠিক আছে, তুমি রেডি থাকো। এখন না দাঁড়াও, ডক্টর অমিতকে একটু করে নিক, টেস্ট করে নিক।
দুজন তো আসে নাই, মিনিমাম সে না আসলে শুরু করা যাবে না। একটা মিনিট।
উনি আছে কিন্তু মিউট করা।
হ্যাঁ, হি ইজ देयर, হি ইজ देयर।
শুরু করে দিই ম্যাডাম, শুরু করে দিই। Learned audience from home and abroad, Assalamu alaikum and a very good afternoon. I am Lieutenant Colonel Dr. Umme Rumal, Classified Specialist, Obstetrics and Gynecology, CMH Dhaka. Rapporteur of this session, welcome you all in the session 10 of 6th International Scientific Conference organized by FSSB. We have 3 eminent speakers from abroad. We are honored to have our chairperson, Professor Roshanara, Vice President, FSSB, and Professor Shaheen F. Siddiqa, Joint Secretary, OGSP, Organizing Secretary of ESP and PCOS Club. And so I'm welcoming you all to our session, which is sponsored by ACI. Now, I welcome the moderator of this session, Professor Tabassum Parveen, Secretary General of Fetal-Maternal Medicine and a Professor of BSMMO, to moderate the session. Madam.
And thank you, Dr. Ruman. Honorable Chairperson, my teachers, speakers, and dear audience. Assalamu alaikum. With the permission of the chair, we are going to start the 10th session of this conference. In this session, we are eagerly waiting to hear presentation from 3 renowned fertility specialists, 2 presentations on poor responders, and 1 about embryology, which is an integral part of ART. It's a gentle reminder for our speaker that time allocation for each one is 20 minutes. Please consider our apology and our humble request to finish your talk in time, as we do have back-to-back programs. Audiences are requested to put their question in chat box. If time allows, our speakers will definitely respond to those questions. Dear audience, poor responders is really a big challenge in reproductive medicine for a long, creating a great deal of impact in ART practice. Apart from our limited understanding about its pathophysiology, there is wide heterogeneity about its definition and also lacks actually a solid recommendation about management. So to talk about this complex and controversial issue, we do have our first speaker of this session, a renowned fertility specialist, Dr. Amit Patke. He has been in fertility practice over 25 years in UK as well as in India. He is the Medical Director, Fertility Associates, Mumbai. Presently, he is Vice President of Indian Society of Assisted Reproduction. He is the past President of the Mumbai Obstetrics and Gynecological Society. He is also the chair of the West Zone India for the Royal College of Obstetricians and Gynecologists. His topic of presentation is evidence-based approach to poor responder. So over to you, sir, and floor is all yours for next 20 minutes.
Thank you very much, and a very good afternoon to all my friends in Bangladesh and all those who are listening from elsewhere. Thank you at the onset for giving me this opportunity to be with all of you. And my thanks extends to Professor Maruf, who has been coordinating with me. Thank you, Maruf, for having me. And the chairpersons, Professor Roshan Ara Begum and Professor Sirin Sesitiki. Today, I've been asked to speak on evidence-based practice for poor responders. And I hope at the end of my 20 minutes, I would have made you wiser on what exactly we can do to help these women whom I think are increasing in number, at least in India. And we see a large number of young girls coming with poor responders or classified as poor responders. So who is a person who can be defined as a poor responder? It is somebody whose age more than 40 or any other risk for poor ovarian reserve, like pre-existing hypertension, diabetes, or any other medical disorders. Somebody who's given a poor response that is less than 3 oocytes with a conventional stimulation protocol, and somebody who comes to you with an abnormal ovarian reserve test, maybe an antral follicle or an AMH. So an antral follicle count, which is less than 5 follicles, or an AMH report, which is definitely between 0.5 to 1.1 or even lower. What are the supplemental criteria? There are 2 episodes of poor ovarian response after maximum stimulation in the absence of advanced maternal age or abnormal ovarian reserve test. So somebody who's young, who you have given her the best dose and still gives you a poor response. So previously we had this Bologna criteria which we were following, but as we all know, it was quite confusing. It did not cover all the women who would come to you because we see a large amount of heterogeneity in the groups that come to us. So now we have this Poseidon working group or the Poseidon classification for somebody with poor responders. And there are basically 4 groups. The group 1 is somebody who's young, less than 35, with adequate ovarian response, but comes with an unexpected poor or a suboptimal ovarian response. The group 2 is somebody who's over 35 years, but having normal ovarian parameters, but comes with an unexpected poor response. Group 3 is somebody over 35 years with poor ovarian reserve test. And the group 4 is somebody with more than 35 with poor ovarian response. So if you look at them by prognosis, the prognosis is best in the young poor responder or an older poor responder, but with a good ovarian reserve. And the poor prognosis is reserved for both the one who is older by age and somebody who's young but has a ovarian response or an antral follicle count or an AMH response which is poor. So how do you manage these patients of poor responders? Now, if you look most of them are retrospective studies. Most of them are underpowered, small number of people. And hence it is very difficult to draw any conclusion from any of these studies. So the need of the hour presently is to have a proper evidence-based prospective randomized controlled trials. So what are the interventions which have been suggested to enhance the response in group of medicines or supplements that can be offered, like growth hormone, pyridostigmine, transdermal testosterone or DHEA, low dose aspirin, L-arginine, and aromatase inhibitors. There are also some suggestions of changing the protocol, so interventions in the protocol. So basically an antagonist protocol, which is compared to a routine agonist protocol, or no suppression cycles, natural cycles, modification in the ovarian stimulation as far as the drugs are concerned, use of techniques like ICSI, and we will run through all these and see if what is the present evidence that suggests whether it is useful or not useful. So the first and the foremost is addition of growth hormone. We know growth hormone enhances effects on the granulosa cells, and we know growth hormone releasing factor induces steroidogenesis by cyclic AMP. But when you look at these meta-analysis, which was published by Kolibinskis in the Human Reproduction Update of 2009, 5 studies having total of 79 patients, so very small numbered meta-analysis, you find that the growth hormone is showing favorite with a risk difference of 17%. So you have a risk difference of 17% when growth hormone is used. This is to be ideally given in a dose of 4 to 8 IU every day. Some recent papers have suggested to start it in the mid-luteal cycle of the previous cycle so that you get a better response. So this paper in 2003 concluded to say that growth hormone addition could have a beneficial effect on the probability of live birth. However, growth hormone releasing factor did not show any benefit. What about addition of pyridostigmine? Now, pyridostigmine is an acetylcholinesterase inhibitor. It increases growth hormone secretion by enhancing the action of acetylcholine. Relevant studies, Kim et al. Of 1999, 70 patients have been studied, and we find that the growth rate, the difference rate is -14, thereby showing us that addition of pyridostigmine did not have any effect on the ongoing pregnancy rates or on the delivery rates. And the paper concluded to say that addition of pyridostigmine does not improve the ongoing pregnancy or deliveries in patients who are poor responders. What about role of androgen in follicular growth? So let's go back and see how androgen influences follicular growth. It acts as a metabolic precursor for steroid production, serves as ligands for androgen receptors, promotes follicle recruitment by insulin-like growth factor, and it also suppresses apoptosis, and hence you get better oocyte and embryo quality in the cohort of embryos that are produced after addition of androgens. So androgens can be given by addition of transdermal testosterone. This can be used once a day. We generally would like to start it a month before the IVF is done. Relevant study that we have taken is Massin of 2006, 53 patients. This was an agonist recombinant protocol. And they found that the rate difference was 4.3, not statistically significant, but showing a better response to patients who have used transdermal testosterone. Now, remember, this transdermal testosterone has to be stopped maybe a day or two prior to the ovarian stimulation, so needs to be given in the previous 1 or 2 cycles. And they said that it does not appear to result in an increased probability because the risk difference was only 4.3, but pointing towards possible benefit. The other way you can increase androgen is by the use of oral dehydroepiandrosterone, which is DHEA, which is freely available over the counter in the US, in Europe, and certain countries, a reasonable assumption is that DHEA is an essential substrate for steroidogenesis. So when you have very low DHEA, you have a low substrate for the production of androstenedione, testosterone, estradiols, and all these low concentration of hormones will give you a low FSH. Gleicher in 2005 published this case report where he found a woman who used to come to him at the age of 38 in a subsequent oocyte retrieval cycle, started giving him better number of oocytes and embryos. When he closely interrogated her, he found that she was taking this DHA, which was available over the counter. And that's how he produced this paper, showing that in the 8th cycle, she gave almost 18 oocytes, of which 13 became embryos. His colleague Barad et al. Published in 2006 in the Human Reproduction, a paper where he compared 25 women pre-DHA and post-DHA, and he found that the number of embryos that were present when DHA was given in a dose of 75 milligrams daily, at least 30 to 90 days prior to the cycle, they found that the number of embryos were better, and they also had a better pregnancy rate. Barad subsequently produced a paper where he compared DHA to controls, in which he clearly showed that the clinical pregnancy rate was much better in the DHA group, and the miscarriage rate was also surprisingly much lower in the DHA group. And that's how Gleicher and Barad, both of them, aggressively propagated DHA supplementation in women 1 to 3 months prior to their IVF cycles. And they found that women who were younger, less than 38 years of age, demonstrated a better response. And they also found that if the AMH became better after 2 months, these women gave them a better success rate. And they found that the DHA also had a lower miscarriage rate, and hence they advised to continue the DHA till 8 weeks of gestation. This is the national miscarriage average compared to the patients who are on DHA. And if you look the DHA group, in all the patients over 35 have a lower miscarriage rate than the national miscarriage rate, which is averaged for the USA. So this clearly showed by some unique pathway, DHA not only gave us a better response, maybe they rekindled the oocytes which are dormant in that patient, but also reduced the rate of aneuploidies when these oocytes were used, thereby giving you a better take-home baby rate. What about addition of aspirin? We know that there are beneficial effects of aspirin because it increases blood flows, and it has been shown to be of benefit in patients undergoing frozen embryo thawed embryos or in the recipients in the donor oocyte program. But aspirin was used for patients of poor responders, the relevant paper of Locke of 2004 of 60 patients, they found that in fact aspirin reduced their pregnancy rates, and hence the rate difference was minus 3.3, and they did not, and they concluded to say that there was no beneficial effect of adding low dose aspirin in poor responders undergoing IVF. What about addition of L-arginine, essential amino acids? We know L-arginine increased vascularization, helped to grow and mature follicles in both natural and IVF cycle, because L-arginine produces nitric oxide, and we know that nitric oxide in peri-ovulatory, it is a vasodilator, will increase the blood flow. And hence, when arginine was tried, the relevant study of Batalgia of 1999, again having a small group of 34 patients, they also saw the cumulus oophoris outcomes and pregnancy rates, but they concluded to say there was no beneficial effect in patients with poor responders with addition of L-arginine. What about addition of aromatase? We know aromatase works on the negative feedback of HPO axis. That way it will increase the FSH, and maybe it will work on the insulin-like growth factors, stimulate those receptors, and maybe it will work better. Aromatase inhibitors have shown to induce ovulation in PCO patients, and it was also thought to be a good, attractive option for poor responders. Relevant paper of Goswami of 2004 of 38 patients, long protocol. They looked at pregnancy outcome, and they found that the pregnancy outcome as compared to placebos was almost the same. So concluded to say that aromatase inhibitors does not appear to improve clinical pregnancy rates in poor responders. So we have seen in the addition, the supplements, perhaps growth hormone and androgens are the only two which have shown a better pregnancy rates, maybe not statistically significant, but showing us a risk difference which ranges from 4 to 14. What about modifications of the stimulatory cycles? And I'm not sure if my next speaker, Anu, is going to talk on this, but there are different dosages of GnRH agonists, different protocols of using antagonists, all in the hope that we would get a better response in poor responders. So the next 10 minutes, I'm going to just run through some of these modifications. This was a study which compared standard long luteal down regulation versus stop agonist long protocol. And the other relevant study of Garcia was when they compared the stop versus the non-stop protocol. In both groups, they saw the outcome as pregnancy, and they found that the rate difference between stop agonist versus the standard long protocol was 2.4, and in the non-stop versus stop protocol, the rate difference was 3.7, not significant. So they concluded to say that modifications of the long agonist protocol does not appear to enhance the probability of pregnancy over the conventional long protocol that we use. What about modifications of the short protocol, or comparison between short and the long protocol? Weisman in 2003 compared the short protocol versus the long protocol, but did not seem to have any better response in both the groups. What about comparing antagon versus the agonist protocol? Again, Greisinger in 2006 had a meta-analysis of 575 patients where they found that maybe the odds ratio was 1.2 favoring antagonist, but certainly did not have any statistical significance. So maybe the antagon protocol will give you slightly better response, but is not significantly better. So comparing the antagon versus no pituitary suppression, Ackman of 2040 patients, ongoing pregnancy rates, we find that the clinical pregnancy rates in the antagon group was much better. So you have to give some method where you suppress the LH, otherwise your pregnancy rates are going to be devastatingly lower. So antagon or agonist is necessary. You cannot do a stimulation protocol with no pituitary suppression because that is not going to help. What about natural cycle? Again, Morgia of 2004 129 patients, compared natural cycle versus short agonist cycle, found the pregnancy rates to be almost the same. Hence, natural cycle IVF that we think is going to help patients, or embryo pooling that we sometimes advocate to poor responders, may not be really ideal, because we have seen meta-analysis that freezing embryos may not really help in these patients. So to conclude my talk, I would like to say that whether you do a long protocol, whether you do an antagon protocol, whether you do an ultra short protocol, whether you use FSH or recombinant, or whether you use FSH and LH, we have seen that it really does not make much difference. Although there are papers to suggest now that FSH and LH should be started from the beginning of the cycle, because LH receptors would perhaps give us a better oocyte quality. Does ICSI help? Available evidence does not support the use of ICSI over conventional IVF, and hence we would not really suggest that pregnancy rates are better in ICSI for poor responders. So to conclude, the management of poor responders is still an enigma, with the exception of co-administration of growth hormone and possibly transdermal testosterone and DHA. None of the other supplements appear to be beneficial. The studies for protocol change are very small, single, underpowered, and we need something more better. So what is the eye opener as far as poor response is concerned? Munne in 2012 published this paper saying that with age, the number of abnormal embryos increases, or the number of normal embryos dramatically comes down. And this is dependent on the number of blastocysts also that are formed. So if you have approximately 1 to 3 blastocysts and the woman is less than 35 years of age, you will have 60% of the blastocysts being normal and 40% being abnormal. And if you have a woman who is more than 40 years of age, you will have only 22% of your blastocysts being normal, whether she gives 3 blastocysts or even if she gives you 7 to 10 blastocysts. So what is the alternative? As William Harvey has said, all life is from eggs, and the donor oocyte program is a highly successful program in patients with poor responders or group 4 of the Poseidon, because the success is related to the age of the donor, the number of embryos transferred, and the high success is perhaps because of no hyperestrogenism, no premature luteinization, and better window of receptivity. Thank you very much for a patient hearing. I hope I'm able to solve some part of the mystery of poor responders. We await for Dr. Anu Chawla's lecture to see how she would help her patients of poor responders. Thank you once again, and thank you to the organizers for giving me this wonderful opportunity.
Thank you, sir. It's really a brilliant evidence-based talk, sir, and will definitely help our ART specialists in their practical field. We are very delighted to hear that there is possible benefit we are getting from transdermal testosterone, as well as promising result with DHEA. Thank you, sir, once again. So it's now time for understanding the science behind successful assisted reproduction, the embryology. We have a world-renowned clinical embryologist with us as our next speaker, Dr. Alpesh Doshi. He is an ASHRAE-certified senior embryologist and the founder of IVF London. He is also co-founder and director of the Embryology and PGD Academy in India. Dr. Alpesh is among one of the first scientists to bring the egg and embryo freezing technology of vitrification to the UK. He is a world-renowned expert in the biopsy of human embryos for genetic testing. Dr. Alpesh authored several papers in high-impact journals and written several book chapters. His topic is on what clinicians should know about embryology. To you, sir, your time is 20 minutes. Over to you, sir.
Thank you so much. Can you hear me?
Yes, we are
Lovely.
hearing you and seeing your slide. Please
Thank you.
go to the slide show, sir.
Yes. Yeah. Okay, brilliant. Thank you so much to the organizers for the kind invitation. And thank you for the kind introduction, Dr. Praveen. So today what I'm going to be speaking about is what every clinician should know about the basics of embryology. And I apologize in advance if there is some basic information here, which, I'm assuming that clinicians are not aware of, but I'll try and keep the talk quite generic if I can. So we all know that the value of a modern day embryologist is quite intricate to the whole sphere of an assisted conception service. And of course, the role of the embryologist over the years has really diversified from beyond the laboratory. In many ways, we are considered to be technical experts in terms of what we do in the lab, but at the same time, we're supposed to offer quite a bit of a managerial role within the team of lab staff, such as technicians, embryologists, lab directors, etc. So, of course, there's a huge hierarchical model even within the laboratory. Some embryologists also prefer to take a role of research to kind of also play contribution towards publications, research, writing papers, etc. And in many ways, those embryologists that are involved in research eventually end up collaborating with other multi-center trials as well. Of course, education is part and parcel of what embryologists do day in, day out. So as an embryologist myself, I go to 2 universities to give lectures to medical students. So we also have a scholarly role within embryology as well. Of course, it's a very dynamic area of development. Communication is key. We all know that within an IVF setting, but it's even more paramount within an embryology setting because communication within the team members of the lab is very, very important. And of course, it goes without saying that as a lead embryologist, you need to be a mentor or a guide towards all the junior members of your team within the laboratory. So it is quite important to make sure that you do fulfill that role as well, apart from just doing the clinical work day in, day out. So an IVF lab has many facets to it. And of course, for a lab that is planning to start from the beginning, it is important to understand that what are the various parameters that are relevant in setting up an IVF lab. So equipment is key. And of course, depending on how the IVF lab sits within the IVF unit, it may become a turnkey project. And of course, as the project goes along, you will need to put some more emphasis in the consumables, in the training of staff, and ultimately the most important parameter is quality control, which we'll probably talk a bit later. The IVF lab can be broken down into 2 parts, the non-sterile area and the sterile area or the ultra clean area. So let's start off with the non-sterile area. Of course, we have, some parts of the clinical setting which are non-sterile, such as, the autoclave room, semen collection room, semen andrology lab, and even sometimes the room in which the IUI is performed. Although within the UK, now the IUI room comes under the sterile room as well. The sterile areas, of course, are the main embryology complex laboratory, the embryo transfer room, whereby a certain grade of air is required, and typically the operation theater in which egg collections are performed. So as per the regulation of the HFEA, the 3 areas that need to be under the most sterile air environment are where the gametes are procured, such as the operating theater, the embryo transfer room, and the embryology lab itself. So the commissioning of any lab is quite important. It's very important to understand that what are the factors that negatively affect the working of an embryologist, and of course, most importantly, the output of an embryology lab. It is well known that air quality is extremely important in an IVF laboratory, and the level of volatile organic contaminants is crucial. It is extremely important that the level of VOC is kept within a minimal level, because when VOCs increase in the air, so does the toxicity to the embryos. So as a result, we end up working in what we call laminar airflow cabinets, which provide us with very clean, ultra clean air in the vicinity that eggs and embryos are being manipulated. But it is important to understand that even within this laminar airflow setting, there are other consumables that are continuously giving out VOCs. And it is important to reduce these VOC levels by having adequate filtration in the laboratory in the form of activated carbon filters. So we now move on to equipment that is essentially needed in an IVF laboratory. So typically, as I mentioned, that we need laminar flow cabinets. The heart of any IVF unit is incubators. So typically we need CO2 incubators, and ideally CO2 incubators that are able to reduce the oxygen level within the incubators as well. Incubators come in many shapes and form nowadays, right from the big box incubators to what we call the benchtop incubators. And again, we'll probably discuss a bit of this later on. You need heated stages over which all the manipulations are happening. You need centrifuges, microscopes, sperm counting chambers. And of course, the amount of equipment or the number of equipment is depending on the number of cycles that the clinic performs. And the more cycles that are performed, the more equipment of the same kind that you will need or need to replicate. Whenever you do have equipment, it needs to be validated. It needs to be calibrated, and it's very, very important for all this validation and calibration to be documented so that in the event there are inspections, you are able to demonstrate that as an embryologist, you've taken all the precautions to ensure that there is very little variation in the performance of the incubators or the equipment that is crucial to the running of the embryology lab. Apart from validation and calibration, SOPs are the most crucial in an IVF lab. Especially when you have multiple embryologists that are working in a setting, it is quite important that there is standardization in the operative work that all the embryologists are performing to. And it is very important to have regulated, validated, and standardized standard operating procedures. So we move to sperm. And of course, as we talk along, we will be moving to embryos. Now, we all know that from a nomenclature perspective, sperm analysis can be broken down into various segments. You can have normospermia, whereby the sperm count is more than 15 million. You can have mild oligospermia between 10 and 20 million. You can have moderate oligospermia, severe oligospermia, cryptospermia, and azoospermia, of course, where there is no sperm seen in the ejaculate. There are various studies that have shown that there is more complex methodologies now to evaluate sperm, such as sperm DNA fragmentation. And there have also been studies that have shown the use of testicular sperm versus ejaculated sperm in cases of high sperm DNA fragmentation. But of course, the jury is still out on this, because ultimately in men who do have ejaculated sperm, it might be a bit of a radical approach to get testicular sperm through surgical sperm retrieval methods, especially if they can ejaculate normally. So here we can see a video whereby you will see how the sperm move under the grid. So we take a small drop under the microscope, and the number of grids that we count the number of motile sperm that are available in any such grid. So we move on to another visualization. So you can see the difference that on this slide, the number of sperm that are moving are very few. And most importantly, you will realize that the speed at which the sperm are moving is very, very slow. So this sample can be considered to be astenosospermia. And finally, you will see that in this sample, there is hardly any sperm that are moving. In fact, there is no sperm that are moving. There's sperm there, but there is no motile sperm. And of course, motility is a predictor of viability. So in such cases whereby you see no sperm moving, you may have to move to more advanced sperm selection techniques by subjecting the sperm to, for example, motility enhancers such as theophylline or pentoxifylline. So whenever you do get cases of astenosospermia, the patient would need to be evaluated potentially by a urologist rather than just a gynecologist. Of course, there are many, many reasons why a man or a patient can have absolute total astenosospermia, and these are just some of the reasons that may be the reason for the total astenosospermia. Of course, in cases whereby you have to move to testicular sperm or surgical sperm retrieval from the testicle, this is what the picture may look like in the laboratory. So you've got a lot of red blood cells there simply because we have got seminiferous tubules that have been provided to us in the laboratory in the form of a testicular biopsy, and the embryologist then milks all these seminiferous tubules, and you can see that there's a sperm that has been identified there, and we will be isolating those single sperm, and we will be injecting those sperm in the eggs once they're found. So the start of any IVF cycle, there's various stages to an IVF cycle, as you all know, but it probably all starts with an ovarian stimulation, either in the form of a short protocol or long protocol. And of course, we've got very esteemed speakers who are going to be speaking about it today. But most importantly, once the eggs are collected, this is when the role of the embryologist starts. Right from the point of collecting the eggs to fertilizing the eggs, to culturing the embryos, and then potentially either planning a fresh embryo transfer. And of course, in this journey, there's various stages at which the embryologist has to apply their fundamental knowledge about embryo selection, how to select the best embryo, looking at various competency markers of embryonic development, and most importantly, identifying which embryo is the strongest and gives the patient the best chance of a pregnancy. Of course, it's not always possible to do fresh embryo transfers, and in many clinics, they may have taken a stand to just preserve the embryos and then perform what we call a frozen embryo transfer in order to transfer the embryo back. And of course, this depends more on the clinic protocol, but typically I know many clinics would at least do frozen embryo transfers in 50% of their cycles, if not all. And of course, it must be said that when we are looking at the role of the embryologist or the role of an IVF unit in planning IVF cycles, it is very important to ensure that before you start any IVF cycles, that some of these parameters are checked off on the checklist. Certainly in countries like India, whereby there is a lot of visiting embryologists that move from one clinic to the other to perform IVF cycles, because not all IVF clinics may be large enough in order to have resident embryologists. So firstly, it's very important to check that the embryologist is available when you're planning your batch of IVF cycles, that your lab is equipped with all the culture media that is required, and of course, kept in optimum conditions between 2 and 4 degrees C, that you have all the disposables needed right from egg collection for your embryo, for your theater. You have embryo transfer catheters, you have your ultrasound machines, etc. You have your cryo tanks if you're going to be freezing embryos. And of course, make sure that your embryologist is informed well in advance about the etiology of cases that you're going to be treating. Because if there's certain consumables that are needed, chemicals that are needed, the embryologist will have an opportunity to order them ahead of time. And of course, it is very important to have the communication between the clinical team in place so that everyone is informed right from stimulation to trigger, and everyone is ready on time when they need to be. Now, typically as a mode of consensus, many papers have shown the optimum timelines between egg collection and embryo transfer. So typically egg collection is done at around 36 hours post HCG trigger. And of course, we would, from a lab perspective, we would be treating those eggs in terms of whether they need IVF or whether they need ICSI. Fertilization check is done typically 17 to 18 hours post ICSI or IVF. And in some labs, they may even check for syngamy, which is the breakdown of the pronuclei. So this is a busy slide, but of course just shows you what is essentially needed in a lab, right from monitoring the air quality, making sure that the incubator environment is maintained. We need to check the pH, temperature, gas concentration of incubators. There are certainly daily quality control tasks which are needed to be performed as well, such as temperature checks of all the heated stages, making sure the incubators are also performing correctly. The type of oil that is needed, of course, there's a lot of debate around it, but most importantly, it must be understood that the oil is a preventative barrier which is used in an IVF lab purely to minimize infection and at the same time to maintain temperature and pH of the gametes and embryos. The plasticware that we use in an IVF lab is also crucial. And it is very important to make sure that the plasticware that is used to culture the eggs and embryos are tested for toxicity as well as any kind of contaminants. And the way we buy plasticware in the lab is to ensure that it is MEA tested, which is mouse embryo assay tested, and it is CE marked, which is a European governing standard for its quality. Heated stages need to be checked, and of course, culture media is nowadays bought from companies. So please, I encourage you to ensure that culture media is not made in-house. You have specialist companies that perform all these quality control checks on culture media in order to bring you the best quality of culture media that you should be using for your patients. Now, I'm not going to be spending too much time talking about culture media, but certainly this is something for your embryologists to know. But as a clinician, it is very important to understand that you're using culture media which is fit for purpose. So please do ask your embryologists whether the culture media that they're using, whether it's a single step media, whether it's a sequential media, and if it is a single step media, is it a CE marked media? Are you using a media which is rich in both non-essential amino acids and essential amino acids? Because the embryos do change their requirements as they develop from zygote to blastocyst. So of course, we move on to the egg collection procedure. This is just showing you a video on how these, how an egg collection is performed. And you can see in all these videos that on the video on the left-hand side, you can see that an egg has been identified by the embryologist, and the embryologist is going to be picking up that egg. But whilst the aspiration of the follicular fluid is happening, the follicular fluid has to be kept warm, and you can see that there's test tube warmers there, which keeps the follicular fluid warm. It must be said that the egg is the most temperature sensitive cell in the human body, and it is the largest cell in the human body. So any kind of temperature fluctuations at this point can distort the meiotic spindle of the oocyte, and it can render it to non-disjunction, leading it to aneuploidy in the embryo. So it is paramount and ultra important to make sure that the egg collection procedure is done with utmost care when it comes to temperature. We move further. If I can move further. Okay, so as I said, we need to identify the eggs under the microscope, and you can see that the image there is showing you these black dots in the middle, which are the oocyte, and then all this fluffy mass around it is called the cumulus cells, or the oocyte cumulus complex. So what happens once the eggs are collected? the oocyte cumulus complex is either inseminated with sperm under conventional IVF conditions, or the eggs are denuded to perform ICSI or to vitrify the eggs. So whether you're vitrifying the eggs in the form of egg freezing or fertility preservation, you still need to denude the eggs and remove all the cumulus cells around it, just how you would do for ICSI. So standard insemination, whereby IVF is performed, you would just be inseminating the eggs with around 50 to 100,000 sperm per oocyte cumulus complex. So again, once the sperm has been prepared in the laboratory, whereby it's hyperactivated and you can see the sperm are moving very nicely in that drop, they are ready to attack the egg to fertilize it. So the denudation is also quite important because if you're going to be stripping the eggs for ICSI, you need to make sure that you are subjecting it to an enzyme called hyaluronidase, which breaks down all the oocyte cumulus complex. And you can see that all the eggs are now clean of all the cumulus cells. And what the embryologist is now doing there in that video is that the embryologist is cleaning the corona radiata via pipetting the eggs very, very carefully under narrow lumen pipettes. And you can see that the eggs are now all cleaned up and they are ready for the ICSI procedure. So here is the ICSI procedure itself. And you can see that this is a cleaned egg after hyaluronidase treatment or removal of the cumulus mass. And what's happening there is that the egg is held in place with a holding pipette, which is all done under micromanipulation control. And the embryologist is going to be injecting a single sperm into the egg. There's the sperm. And with careful micromanipulation techniques, and of course you need to make sure that the embryologist is skilled at micromanipulation, the sperm is released in the middle of the egg in order to achieve fertilization. And of course, in many countries, I understand, ICSI is used as the standard method of insemination, but in the UK, we tend to put a lot of emphasis on still performing IVF because there is an element of the survival of the fittest or the best sperm entering the egg via natural selection. So I'm not going to be talking too much about the oocyte cumulus complex because this is more for your embryologist, but just to kind of let you know that the oocyte cumulus complex can be graded as well.
Sorry to interrupt.
Yeah.
Alpesh sir, sorry to interrupt. I am afraid we are running short.
Okay. Sorry, you're breaking up. I can't hear you. Sorry, my time is over.
Please conclude your topics.
Okay.
Early as possible.
I'll be very fast. It's a
sorry.
topic.
Yes.
No
20 minutes has been left. Around 3 minutes. Yes.
I will take another 3 minutes and I'll wind up.
Sorry. My apologies. Okay, sir.
So,
go on, please.
Okay, so as I said, we would just look at the cumulus oocyte complex and then look at the various eggs. You can even have giant eggs, so this is just showing you how the eggs look very differently. It is also important to assess the nuclear maturity. You have metaphase 2 eggs which have released a polar body. You have germinal vesicle eggs which are immature and are still diploid, and you have metaphase 1 eggs here which haven't released the polar body and again are also diploid. So cytoplasmic qualities also need to be looked at. So here you can see that there's vacuoles within the egg. There's multiple vacuoles and large vacuoles within the egg, all showing compromised oocyte quality. There's a smooth endoplasmic reticulum here. There is dark clusters in the egg, and there is a refractile body. So it's very important for the embryologist to be assessing the eggs in very, very good capacity. Some clinics also have the ability to look at the spindle dynamics. So whenever you have an illuminated spindle, this shows you that the oocyte is competent in terms of having the right spindle apparatus. And again, it can be used as a further methodology to ensure that we are using eggs of competent quality. Of course, embryo assessment can be done at any time between the 5-day journey. Typically, embryologists look at fertilization on day 1. They look at the number of cells in the embryo on day 2, day 3, and ultimately they go towards blastocyst to look at the quality. But again, we need some standardization, and there are certainly consensus papers that have looked at what is the ideal timelines to be looking at embryos within the laboratory. And that table shows you how, as embryologists, we monitor the different parameters within the laboratory at certain timelines. Of course, there needs to be consensus at grading of the embryos as well. And again, there's a huge variation in how this is done in the world in different laboratories. But again, there is papers that are coming out which actually are bringing in consistency and standardization and universal embryo grading schemes when it comes to cleavage stage embryos and even blastocysts. Blastocyst grading is also very important, and of course, without getting too technical, embryologists grade embryos based on inner cell mass and trophectoderm quality. So it ranges from A to C with both inner cell mass and trophectoderm. Which day to transfer the embryos? Of course, this is very variable. It depends on various parameters like the number of embryos available, whether you have a selection of embryos, whether the endometrial thickness is fine, what is the patient choice, what is the staff availability like. But typically in the UK, we tend to want to perform blastocyst transfers wherever we can, as much as we can. I'm now going to just spend the last 2 minutes on talking about advanced technologies available in the IVF laboratory. And of course, there's a lot of emphasis in choosing the right sperm. There's a lot of emphasis on using high microscopy techniques such as IMSI, whereby you look at the vacuolation in the sperm head, because the degree of vacuolation has been associated with the level of DNA fragmentation. So again, it's quite important to make sure that we select the relevant techniques in order to do the right procedures. I'm not going to speak too much about sperm separation techniques. There's microfluidics, there is theophylline, as I said earlier. There is various types to perform the ICSI as well. There is piezo ICSI, standard ICSI, spindle view that we've talked about already. And of course, there is more recent time-lapse systems that have shown how embryologists look at these various kind of embryo development patterns. And we also, how we look at these images under time lapse and how we put the embryos side by side to see which embryos are developing better, so that we can make an assessment in terms of which embryo is better in quality and which embryo to transfer or has a higher implantation potential. Of course, on top of everything, we also have artificial intelligence nowadays that can give us an idea of the developmental pattern of the embryos. I'm not going to be speaking too much about assisted hatching as well. Again, one of the technologies that can be used in the laboratory. And finally, my last 2 slides are just going to show you about PGS. And of course, we know that the jury is still out on genetic testing of embryos. But again, embryos can be biopsied in order to look at the chromosomal status, so that you can pick out which embryos are euploid and which embryos are aneuploid in order to select the better quality embryos. So here, this is just showing a biopsy of an embryo, but again, time is short. So yeah, there's a lot of focus on AI as well. AI can also grade embryos based on a score. And of course, finally, I just want to leave you with a slide that the future is very bright in terms of the genomics or various omics, and we're going to soon, in the next year or so, going to be seeing non-invasive assessment of culture media in which the embryo has released cell-free DNA in order to look at ploidy status of the embryo. So thank you so much. Of course, we need to ensure that whenever technology is released for clinical use, we are validating the technology and the technology is robust enough, rather than us facing lawsuits in the past. Thank you so much, and sorry for going way over time. Thank you. Hello, you there?
Thank you, sir. It's really for a day long. It's really so interesting. It's really interesting, sir. Time constants, inshallah, next time within very embryology lab for us and allowing and role of embryologist in making a new life. Thanks for making alert us about maintaining standardization of an IVF lab, as well as need of an efficient and skilled embryologist in getting best embryo for the best benefit of the patient. Thanks, sir, once again.
My pleasure.
So,
Thank you so much.
thank you, sir. So our next speaker is Dr. Anu Chawla. Dr. Chawla has experience in the Madam, okay. Dr. Chawla has experience in the field of active practice for more than 11 years, practicing in St. Bartholomew's Hospital, London. She is the Joint Secretary of Delhi Association of Reproductive Medicine. She is the member of actually almost all the renowned societies of reproductive medicine like SRM, ASHRAE, BFS, ISAR, FOXY. She is the editor of International Journal of Human Reproduction, Research and Development, as well International Journal of Fertility and Sterility, Bangladesh. Her topic is newer concept of ART is yours for next 20 minutes. Thank you, ma'am. Over to you.
Thank you very much, Dr. Tabassum, for a very kind introduction. Dr. Roman, both of the moderators. Thank you very much, Dr. Siddiqui, for giving me this fantastic opportunity. And I actually preceded by two very, very wonderful speakers, both Alpesh Toshi. I'm actually working with him. So this is my old CV, which went with you. So, and also Dr. Amit Patki. And actually I just happened to check just 2 minutes prior to while I was going to start earlier that our topic is actually the same. So it is very challenging for me to do a lecture after Dr. Patki. He has very beautifully covered most of the very important central aspects of the practice that we actually do. And here I will start my presentation. So is the screen all right with you, Dr. Tabassum? Can you see and hear properly?
Hi, Anu. Yes, we can.
Yes, ma'am, it's okay, ma'am.
Thank you. Thank you, Dr. Patki. Very glad to hear your voice. Thank you. Okay, so there are no disclosures to make. And the learning objective is to understand the key concepts and practical nuances involved in the journey of a woman with the poor ovarian reserve or response.
Yes, ma'am. Your slide is showing. Yes, ma'am. Slide are
Sorry? So we have this very beautiful document by one of my favorite authors, Cindy Fucker. She has led this team, and they actually reviewed all of the data for the last 25 years, and based on the 10 critical questions overall in general, which are the main challenges in the IVF practice. And in the section of the poor responders, like Dr. Patki has already mentioned, she actually has supported only 2 add-ons, which I'm going to cover very soon now. This is just as a disclaimer that, you know, in general, the support to add-ons is very, very less, especially we have a new HFEA director now, who is very critical for use of add-ons. And we have to really explain anything that we use. Another thing is, of course, evidence-based medicine is very, very crucial and forms the basis of any good doctor's practice. However, we really have to be very guarded when we see the meta-analysis. Normally, the meta-analysis of the available trials can create a massive bias, because actually the power of the study is huge because it's a meta-analysis. But the studies included in that can be very varied, and they can actually be skewed by a very, very low quality studies. But overall, meta-analysis are very, very tricky, and some people really discourage the use of the same now. There's something new called the individualized data meta-analysis, where we actually take the data from the individual authors and then we reanalyze. We just don't combine the study results. We actually take the data and do the whole analysis again. So meta-analysis is not as powerful always, is the message. Coming back to now the subject of the talk, we earlier had no definition, then we had a definition which was the Bologna criteria, in which one thing was ignored, that how can 3 follicles in a woman of 25 years of age can be compared with 3 follicles in a woman of 40 years of age. Because of this massive drawback point, the concept of Poseidon came. So they have 4 groups. The first 2 are expected poor responders, young and old. And the second 2 are the unexpected, the first 2 are the unexpected, where the reserve is normal, young and old. And the second is actually the expected poor responders, young and old. So 1, 2, 3, and 4, like this. Now, when we speak about the protocols, till 4 years back, most of the clinics were doing antagonist everywhere in the world, apart from 6% of doctors, based on one study, who always stuck with the long down regulation protocol. And one of them was Tim Child in Oxford, who I trained with briefly. And again, in the last few years, there is a U-turn in the favor of long down regulation protocol, the agonist protocol, because of a few studies which have proven that we get 1 extra egg or a few extra eggs. Dose adjustment is very impulsive decision made by many teams. But when we do not expect the poor response, but we see it, then it makes sense to increase the dose. But when we expect the poor response, we are not going to create alive something which is dead by just giving the higher dose. So in those cases, increasing the dose doesn't make much sense. And there is one study, actually, I haven't mentioned it here, I should have done that actually, but in the second part, this the 18 months thing is actually a criteria, which is that if a person is continuous with the treatment and doesn't give up for 18 months, 50% of those poor responders will get their own biological child. You can write an email if you want that study and I'll send that to you. Again, when we choose the dose, anything more than 450 is really not helpful, is the conclusion of this particular study. Here is the conclusion of this study. There are many adjuncts like these, and every adjunct has a very individualized application, and we need to be very careful when we use any of these. So a few of them I will cover in my presentation. There are 2 newer parameters like output ratio, which is the pre-ovulatory follicles with respect to the antral follicle count, and the follicle outside follicular oocyte index, which is the oocytes that we get in the first cycle with respect to the AFC. Now, these are various indices how we are trying to make it an objective calculation for the next cycle. Some of the ART calculators are available freely on the internet to decide for the dose of poor responders, but main aspect is actually covered in the goal is covered in this table, which is that for a woman of less than 35 years of age, the number of oocytes that should be the goal should be 8. And if you see 40 to 42, meaning at least 12. So also there's a concept of one and done, which doesn't really apply to a poor responder, but if possible with the higher dose of 450, not more than that. We should be aiming for that. But of course, Dr. Patki has already spoken about the embryo pooling. We'll come to that. I will skip this slide. This is just a further extension of the previous because we really do not have followed this, so I will not be a right person to talk about that. Just wanted to mention that. So role of CC. When I briefly trained in New York with Dr. Zhang, he used CC very often. Now, the ways clomiphene is one of my favorite drugs. It is a very time-tested drugs. And because of the newer drugs, it is shadowed, but it can never be overshadowed by anything. In the case of poor responders, especially in their third, fourth, fifth cycle, if they still want to stick with the own eggs and do not want to shift to the other options, then clomiphene actually is apparently working in a way that the endogenous FSH from the pituitary is basically this FSH which is created is a different isoform than what we give from outside. So maybe this is why clomiphene actually is a class apart drug as compared to when we talk about any other stimulation kind of. So maybe in those cases where we are almost giving up, we should do this protocol and maybe we'll get less but good quality embryos. Very reserved about the use of growth hormone because of the two main issues. The first is history of diabetes in the family and plus history of cancer in the family. In those cases, the use of growth hormone can become a medical legal challenge for the doctor. If not, and if carefully used with reasonable doses, if you see most of the studies use the dose of 1 unit, which is actually way less than what is actually being used in the clinics. So very carefully, we can use it. Pre-IVF treatments, out of all the pre-IVF treatments, estrogen valerate, that is what we use, Proganova, or so the estrogen valerate is apparently one of it tick boxes the most good parameters, like it actually improves the harvest in the end. Similarly, and use of antagonist is almost equivalent or second best, like Dr. Patki, I think, already mentioned in his talk. So there are many, but when we do analyze the evidence, we see that 4 milligram daily from day 20, the use of Proganova might help in cases of poor responders. Again, this is another study which says that if you see the yellow marked area of the slide, the live birth rate per transfer is better, almost double in I'm not going, it is too far-fetched probably, but this is one of the studies. So the live birth rate per transfer is more in the case of the long down regulation protocol as opposed to the antagonist protocol. So if I give one message today, if nothing else, the one message that I want to leave today is please consider seriously using more of the agonist protocols in the cases of poor responders. Yes, so coming back to the first slide of Cindy Fucker. So on the right side are most of the adjuvants that they have studied, which is actually not supported with enough evidence. And if you look at the left side, so we have only two. One is DHEA or testosterone, meaning use of androgens. And then when I was training with Norbert Gleischer, who actually is the pioneer of this concept, pioneer of IVF itself, I would say. He is very old, very actively still practicing. And he checks if the patient is willing, he just gives it straight away. And if the patient is not willing, then he checks the testosterone levels, I mean, all the androgen levels. And if they are in the norm, in the lower 1/3 of the normal range or lower than that, then in those selected cases, he does use DHEA. He was the main proponent of DHEA use. And after my training with him, I really changed my practice. And in UK, we don't really need to give a prescription, so they can just go over the counter, buy DHEA, or even order on Amazon. The second one is adjuvant growth hormone, which is, again, if carefully used, is probably one of the good adjuvants. Now, also one more thing I would want to just touch here is that There was something called as rebound phenomena, which I learned with Norbert Gleischer, and I do use that concept when given a chance, that if there is no response, we just stop everything and we just bring the patient next week, and actually we restart from there, because normally that priming of gonadotropins has created a little rebound in sleeping music. So it's like an orchestra is replaying, and it takes time to get the tone right. So in a poor responder who is already the axis is depressed, if we give gonadotropins, there is no response, we just stop, we bring them back a week later, and then we restart again, we can really expect some more activity to happen there. And this is what actually he is going to put up, maybe he has already done that. So almost a year back, I was told that they were putting a publication on this, and it's a really good concept for them, for the poor responders. Now, this already is covered by Dr. Patki's talk, T-transport trial. I'll not spend too much time on this slide. But again, this is going to, because the good thing about this trial is that they have actually used it for 60 days. All other studies have not used it for 60 days. So, and that is the minimum that we expect based on the knowledge of physiology. Now the three coming to now, I'm actually going to point towards something we all know is new, is called duostim. Now, the concept is there are three theories of how the follicles develop. So when we first started medicine, we knew that there is one lunar cycle, something happens every 28 days, people bleed, women bleed, and then there's one cycle, one egg released in the middle of the cycle. But I think that is a little too basic. So there is something more going on. There might be 2 or 3 waves of follicles. Actually, just yesterday, I read a study in which it was clearly mentioned that 68% women have 2 waves and 32% women have 3 waves. And some women can have continuous waves, but maybe we don't know and we're just guessing and something else is going on, so we don't know. So, but the concept is there are more than 1 waves. And because of that, so all of these other studies actually, which are based on the multiple waves concept. And then this is, so the researcher in Italy, Filippo Baldi, he has introduced this concept. And why should we actually, so duostim is actually, we stimulate, we do the egg collection. Important thing is we do the agonist trigger. After a few days, we just start again, and then we do another egg collection. So it's a 2 cycles packed in one. But what is the need? Why are we doing this? Why are we not waiting for the next month? The reason is that probably the estrogen priming that happens for the follicles in the first follicular phase is going to help in the luteal phase for them to perform. Now, in this situation, we might be actually egg collecting in a time when the patient is having periods, but that doesn't mean anything. So now also we might be actually, so the final transferable blastocyst yield probably is higher, plus maybe we get more euploid blastocysts, but we need more studies on that. Now, one point I wanted to add here is, in cases of poor responders, please do not use or please discourage the use of OC pills in your teams, because they are really no good. Especially, I mean, the Sherman Silver is one old practicing, very, very powerful, high caliber researcher. He favors that only in cases of PCOS to prevent OHSS. Otherwise, in poor responders, pre-treatment of OC pills can really prolong the overall stimulation time, and plus the use of the number of ampules and the number of dose required. That means they are actually not performing as well, and we are pushing them harder and longer. So it is also explained by the fact that when we used donors for them, for the poor, so when we just stimulate a donor, mostly they're young girls and they're using OC pills, the endogenous LH is so low because of that agonist trigger doesn't work, and we want to give agonist trigger to them because we want to keep donors safer. So in every way, OC pill pre-treatment is really not my favorite. Mild, I think Dr. Patki has covered this point. is just the only point that I would just make after working in a unit which is one of the pioneers in the world for mild treatments is that the good thing is that probably the biological efficiency is higher, that maybe they are better quality eggs. But the moment we get more number of eggs, more than a few, then conventional becomes the first choice after working in all types of units. My conclusion is that for the poor responder, first I do a very high dose, good dose cycle. For me, 300 is very high, honestly. So a good dose cycle. And if I consistently do not get the result, then I discuss with the patient, because the main problem and the main message I want to tell the patient before she agrees is the aim of this cycle is to get one egg. So is she happy to spend that much money on one egg? Assuming that we do not have much study, but assuming that that might be a good egg. So it can be a last cycle for somebody, or it can be a second, third, fourth cycle for somebody based on their acceptance of the fact that the aim of this protocol is actually to create only one egg, and anything extra is actually the bonus. We might get 3, but this is now how we treated. The way we treated, our goal was to get 1. So this actually applies to very poor responders. So that means the moment somebody is having more than 3 follicles, they are not a good candidate for mild. They are a better candidate for the normal conventional IVF to begin with. Triggers of various natures can help us, especially when we do not get enough mature M2s. Obviously, the preliminary treatment of BMI, smoking, there's a new drug called resveratrol, which is the red grape skin and all the antioxidants. We can do all that. But in the final thing, the trigger is going to actually create some difference when it comes to, if you see the dual trigger, this is the, you can take a screenshot of this maybe, but the dual trigger is helping us in increasing the live birth rate sometimes, clinical pregnancy rate and fertilization rate. And the dual trigger most commonly used is this. And the other good thing, other important thing that I want to convey is that the agonist has to be given 40 hours prior and the HCG has to be given 36 hours prior. It's not at the same time. So please mark that point to the egg collection. So again, PGTA, very difficult. If it is too few, I don't think it is making much sense to do it. But if we have more than a few, then we can check them to prevent miscarriages, because again, in the older section of the poor responders, miscarriages is a very big challenge. And also psychologically, and the time to pregnancy, which is a newer concept of the judgment of the quality of the doctor, how quickly you make your patient pregnant. So very selective, good, proper, justified use of PGTA can help. Carrier mapping is a new way how we see the genetic problem. So this is the latest technology, basically, which is the SNP array. We actually check what is the aneuploidy based on this technology, and people who are more interested can read more on this. Is very widely used in the, this is how the result comes. And future, I will quickly touch a few points before I close. I'm going to close very quickly now. So of course, so this is one of the, I think after vitrification, the biggest next big breakthrough is this, which is the clinical application of the space. So what we do is we take the donor egg, we enucleate that, and we take the nucleus of the poor responder and put the nucleus of this in that. So actually it is as simple as this, but technically the fusion technique is one big challenge, because of which some units are not still able to generate the result. But this researcher, who is Nuno Costa Borges from Spain, he's also working with the Zhang's team in New Hope Clinic in New York, and they are doing the cases in Greece, and they have created a registry there, and they already have live births now. And earlier the problem was heteroplasmy, that the two components of cytoplasm can create a problem. But in the recent data that they have shared, the chance is less than 1%. Earlier it was significant, which was 16%, which actually stopped the evolution of this technology when first it was started by Erie, called augment technique. So because of heteroplasmy, they had to stop. And that is why it is important. Sherman Silber, I think world's one of the oldest IVF practicing person. He's working with his student in Japan. Hayashi is the name of his student. So they are creating sperm. They've already created mice from the skin cells. So very soon, hopefully, at least a few years to go in practice, we might be able to create at least sperms from the skin cells. So this in vitro generated and also oocytes. So both sperms and oocytes can be generated from the somatic lineage, and actually it is based on the mRNA switching on of the somatic fibroblasts. In vitro, so they do undergo normal epigenetic process, just as a disclaimer. I don't have enough scope to go more into the detail of this point here. Another one very interesting thing which one of my colleagues in New York is doing is he's doing a new needle-free IVF, which is very attractive as a patient. So this tablet elagolix is FDA approved, available, which is used as an antagonist. And before that, we use the CC as the stimulation. So the number of needles basically decrease because why this is important is that these poor responders are then able to repeat and repeat and repeat many times because needles are not involved. So the only needle sometimes involved is the egg collection needle, but that time they are sleeping. So it becomes more acceptable for a patient to undergo, say, 7 times and then ultimately create a euploid blast to have a chance of their own biological child. Now, ovarian tissue auto transplant also is a very, I think Dr. Pai is already doing it. I'm not aware of more units, but I am sure there are more units in the world. I know about Oxford here who are doing that and who have collected data already. Another part in the oncofertility patient of poor responder group is the scaffolding is built artificially, and then the matrix and the proteinaceous scaffold pocket is used as an artificial ovary. Sorry. And obviously when the survival rate of cancer is increasing, so we really are going to have more kind of these patients. And this might be very helpful also for the gonadal dysfunction patients like undescended testis or things like that. Erica is another thing. My good friend Alexandra Badiola, few years back in New York when he gave this talk in again the Zhang's conference. That time I came to know about this, and Dr. Pai has already started this, other units have started. And it is actually, we also have this here in our unit. It's very easy that we just calibrate the camera based on their settings. We take the pictures, it goes in the cloud. They check the parameters and do the prioritization so it's a non-invasive method. And in the paper published in Lancet, the accuracy level matched with the PGTA is as high as 80%. So just by looking at it and taking pictures, the computer and the artificial intelligence methods are used to analyze the parameters, and then we just grade. So we choose which embryo to transfer first. Obviously, after the Australia incident, and in general, we should not be discarding those embryos, but we should be prioritizing them. So we put number 1, 2, 3 based on whatever test we do, non-invasive, or we do PGT or ERICA. But we do the prioritization, and we do try to decrease the time to pregnancy, but we still keep the other ones just so that the medical legal problems are avoided. And precision medicine is another thing in the future that is going to help us a lot, because the subjectivity and the variations of the doctor to doctor, place to place, we really need to make things more accurate and precise, because patients are not aware of the differences. So if we create a system that most of the practice is standardized and good, obviously, even if individual, that means we need to create more protocols when we need to individualize plus standardize across the world. And precision medicine is going to help that in future. And thank you very much for a very, very kind invitation. And Dr. Siddiqui has always been so kind in every suggestion that I've made in the society as the editor. And thank you for the opportunity. And I'm always with you. Thank you. Thank you so much.
Thank you, ma'am, for your brilliant presentation, I must say. So I'm afraid I can take only one question for each speaker. Let's start with Dr. Anu, madam. Ma'am, no question to you, but one of our participants, Dr. Mariam Faruqi, wanted to know the timing of dual trigger. She missed it. So
the triptorelin point two is given 40 hours before the egg collection, and 6,500 units of HCG is given 36 hours before the egg collection.
Okay, thank you, ma'am. Is Dr. Amit Patki sir is here? Sir, are you hearing me?
Yes, I can hear you.
Okay. Okay, sir, one question for you. When we have to decide that there is no other option rather than to advise ovum donation for our poor responders?
See, it is a very difficult question to answer, and no one size will fit all. I think it is very important in your counseling to give them a realistic assessment of their problem, and to tell them exactly what are their success rates. Because I've had patients who are happy to take a 5% success rate, and I have some patients who are not happy to take a 65% success rate also. So it depends on what the patient is looking at. I often tell the patients that as a doctor, for me, your success is the most important part. But for the patient, they have to be emotionally connected to their problem. So as a doctor, I'm going to look only at the success rates. But for the patient, they have to see whether they actually want to go ahead with donor. Some patients may not choose to take that path and may say, we are fine, happy not to have any children except our own genetic child. Some people are happy to go for adoption also in such cases. But what is important is that as a treating doctor, we are supposed to give them all those options. Then it is for the couple to decide what is best for them. Because as I said, one answer will not be same for two couples. So they may think differently. They may have different views. They may have different religious practices, the cost. So everything matters. But I think as a treating doctor, I am supposed to inform them about donor eggs. I'm also supposed to inform them about adoption. And I often tell patients, doing nothing is also an option, because you have listened to me, you have understood your chances, and now you take a call of doing nothing. So I think that is what is important. Counseling, especially in poor responders. As Anu said, if somebody is going to take treatment for 18 months, they have a very, very high chance of getting pregnant. But that means that your counseling has to be very good. You're supposed to provide all the support systems, a counselor, a nurse manager. So it depends on the full team who talks to them and what they understand and go back with.
Thank you, sir. It's really a complex and critical issue. So over to Dr. Alpesh Doshi. Sir, due to time constraints, we couldn't hear from you about prenatal genetic diagnosis, PGD. As a fetal-maternal medicine specialist, my interest goes on it. What is actually the common indication you go for PGD? Is it for better pregnancy outcome or for genetic screening? So for other, for unemployed screening or others? What is the commonest indication in your experience, sir, in your setup?
In my experience, PGT needs to be looked at two different scenarios. One, which is to optimize success rates potentially, and the jury is out. And we call this aneuploidy screening, or PGS or PGTA. So certainly the technology can be used to potentially identify more competent embryos when we look at comprehensive chromosome screening techniques such as PGTA. However, PGTSR and PGTM, or commonly referred to as PGD, is more for diagnosing inherited genetic disorders such as thalassemia, such as cystic fibrosis. So they have to be looked at completely differently, and there's certainly different requirements for different set of patients. If you're looking at purely in terms of optimizing or potentially optimizing success rates following IVF, it's PGTA that is commonly used. But if you're looking at helping someone eliminate a genetic disorder from their gene pool, such as breast cancer, BRCA mutations, then it is PGD or PGTM.
Thank you, sir. Thank you, sir, for clearing the issue. Now it's the time for the remarks of our chairperson. May I now request Professor Roshanara Begum Madam to give her remarks. Before giving remarks, Madam, happy anniversary from our side, from our desk. Madam, are you hearing us?
Thank you, thank you.
Happy 47th anniversary, ma'am. So please give your remarks about the session.
Thank you, thank you. Thank you, our rapporteur and our Rahman and moderator, Professor Tabassum Parveen, and for the excellent moderation and your just conducting the session. Now it is the high time. Actually, for 2 days we are here, and but I must appreciate our 3 speakers for their wonderful, informative, evidence-based, and basic embryology presentation. We, FSSB, grateful to you for take this opportunity and to take this trouble from the because of only for the COVID situation we are in the Zoom connection, but still you all are here. So our thanks from the FSSB to you. Again, thanks to the participants who are still sitting in our session. And I must congratulate all the participants and all the speakers, all the moderators, and all the rapporteurs. Thank you again. Over to.
Thank you, madam. Thank you. Thank you. May I now request Professor Shehrin Farhad Siddiqa ma'am to give her comments. Ma'am, unmute, please.
Okay. Thank you, Dr. Tabassum, for the excellent moderation, and also thank you, Lieutenant Colonel Dr. Rumal for the sweet welcome note. Assalamu alaikum, and very good day for everybody. I do express my deep appreciation to the organizer of Fertility and Sterility Society of Bangladesh, especially my deep respect to our respected teacher, Professor Tejudi sir, for the cherishing leadership, and also to Professor Maruf Siddiqui for the excellent team approach and the dedicated hard work for this excellent session. And I'm really proud and honored to be here to chair the session. And this is a good session. I'm also privileged to see my another mentor, Professor Roshanara Begum, along with me to chair. Along with me. Thank you, madam. Actually, this session is a very important session, and where the topic is the challenging topic is the poor responders of ART, and we can see 3 world-renowned speakers along with us. I'm really honored and very much happy to see all of you. And ladies and gentlemen, as we all are thinking about the non-responder, and non-responder is that we are taking this challenge each and every day. And as because of knowledge, there are what to do with the low reserve, how to improve the ovarian reserve, which IVF protocol is suitable, and what are the best options for the treatment for the repeated failure. I think all the challenges has properly covered by all the speakers. If I go for the one by one, our first speaker was Dr. Amit Patki. He's our long trusted friend, and he has spoken about the evidence-based approach of poor responder. Very nicely, he mentioned that we are using so many things like growth hormone, pyridoxine, androgen, DHS, and aspirin. But in evidence-based way, he mentioned that only the growth hormone and the DHS is the things to consider to improve the quality of the poor responder. I think it is a very good information to all the participants who can hear today's information. And the next thing he mentioned the different different protocols, and it is definitely very good. And I think it is a very nicely, elaborately, he mentioned everything, and it is very beneficial for we all. Definitely, thank you, sir. And finally, he mentioned that the donor egg program is the best for the success. Unfortunately, this is not practicing in our country, as it is not our law doesn't permit. And this is why we always appreciate the last word as adoption. But Professor Tietuli sir is along with us all the time. He's doing his practice and he's managing the patient, and he has given the last option as adoption that we want to do as donor. Donation is not actually possible in our country. So thank you, sir, Amit Patki, and you are the person who is actually looking after our law, many of the patients from our country who are the poor reserver. And from the patient side, from the country side, I'm expressing my gratitude to you, sir. Thank you, sir. Our next speaker was Dr. Dr. Alpesh Deshi. And he has spoken about he's the consultant embryologist and the founder of IVF UK. Congratulations, sir, for this your high peak space. And your presentation was the basic information of the embryo. And you very nicely said that every clinician should know about the embryology, and embryology field is beyond the lab. Definitely, sir. The manager, the researcher, collaborator, scholar, mentor, and the technicians, definitely, sir. And another one thing you mentioned, that the sterile and the non-sterile area, actually what you mentioned that the semen analysis, that means semen collection should be taken in the sterile zone. Is really we are practicing in this way. And another one thing you mentioned that there should be the standardized regulation, and the validation of the standardized to lab is required. I think it's a good practicing. And actually what we need to collect the selection of the oocyte is very important. Good quality of the embryo is again important, when to transfer. So we think the regular training and updating knowledge is very much required for that. Thank you, sir, for your excellent presentation. And our last speaker is Olma Chawla. She's a beautiful lady, I can see. And her area was the newer concept of ART. Many of the things are actually were taken with the Dr. Patki. But what is the additional thing I have seen? One is the clomiphene is her favorite drug, where for the poor responder, for the more effective, more egg, and more good quality of the egg. This is thank you, madam, for your excellent And another thing you mentioned that the use of the growth hormone, it should be very selectively used, as because it may causes the danger to the patient who are actually diabetic. So definitely we will follow that one. And for the classification, you are following the Bologna classification. This is very good way. Finally, I want to say one thing. From today's elaborate and excellent presentation of all, I think all the participants are very much benefited. And from the Society of FSSB, from the participant side and from the Bangladesh side, we are congratulating you all. Thank you very much. And thank you very much, everybody, for the patience hearing.
Thank you, madam. Thank you for nice words. So with this, we are near the end of our session. My heartfelt thanks clarified our session. Thanks to the speakers for presenting the complex issue in easily understandable way for us, which is really not an easy task. Thanks the audience for being with us. My special thanks to the organizer, especially Professor T. A. Chaudhary sir and Dr. Maruf for making me a part of this prestigious webinar. I'm really honored. And it will be incomplete if I don't give thanks to my co-moderator, young, energetic, and very enthusiastic and hardworking Dr. Ruman. So over to you, Ruman, to conclude the session. Please unmute yourself. Please unmute. Yes.
Thank you, Madam. Good afternoon and Assalamu alaikum, my learned audience. It's a matter of pride to give vote of thanks after such successful and excellent session. I'm very much thankful to FSSB for giving me this opportunity. My special thanks goes to our chairpersons to conduct the session smoothly and successfully. My heartfelt thanks goes to all eminent speakers for very informative presentation which enlightened our knowledge and enriched our knowledge. I want to thank all our delegates and for their persistence present and patience hearing. I want to thank my Professor Tabassum for her excellent moderation. Thank you ACI Pharmaceuticals and all the persons behind this session. So this is the end of our session. Now it is time for a commercial break, and then we will switch to the next session. And I'm requesting Dr. Sanjukta Chaudhary to run the next session.
Start.
Thank you, Dr. Ruman. Honorable Chairperson, eminent speakers, dignitaries, and all the participants, home and abroad. A very good evening. I am Dr. Sanjukta Chaudhary, Junior Consultant of Gynae, now working my FCPS subspecialty course student in fetal-maternal medicine in Bangabandhu Sheikh Mujib Medical University. I'm very delightful to get the opportunity to welcome you all the 11th session of the 6th virtual FSSB online conference. It is the near last but not the least session. Our today's topics is polycystic ovarian syndrome and male infertility. This session will be chaired by Professor Begum Nasrin and Professor Afroja Kutubi Madam. Professor Begum Nasrin Madam is the chairman of Department of Obs-Gynae, Bangabandhu Sheikh Mujib Medical University. She is the Entertainment Secretary, OGSP, Joint Secretary of Bangladesh Perinatal Society, and Publication Secretary of EASP. Our another reputed and eminent chairperson, Professor Dr. Afroja Kutubi. She is the professor and head of the Department of Obs-Gynae, Sir Solimullah Medical College and Midford Hospital. She took her graduation from the Dhaka Medical College Hospital. She is a fellow of Bangladesh College of Physicians and Surgeons. She is the life member of OGSB, FSSB, and ACLSB. She had more than 25 publications in different national and international journals. Our session will be moderated by Dr. Sumia Bari. He is the Associate Professor of Enam Medical College Hospital, Department of Obs and Gynae. She trained in gynecological endoscopic surgery and ART and fellow in infertility and reproductive medicine. Our three eminent speakers will be Dr. Louis Hall, Dr. Moriam Faruqi Shati ma'am, and Dr. Nusrat Mahmood ma'am. This session will be powered by Popular Pharmaceuticals. Now, I request Dr. Sumia Bari to take the charge from me and conduct the session as a moderator. Charge to Dr. Sumia Bari.
Thank you so much, dear Dr. Sangjukta Chaudhary, for your nice introduction of this important session of 6th International Virtual Scientific Conference of Fertility and Sterility Society of Bangladesh. It's my honor to today moderate this prestigious session. I am very grateful to Professor Maruf Siddiqui who gave me this opportunity. And my privilege that I'm going to let you know that Professor M. Lewis Hall, Dr. Nusrat Mahmood, and Professor Mariam Faruqi, the three legends in the field of fertility and sterility society, will going to share their experience presentation. And with the permission of the chair, I'm going to introduce with these legends. First of all, our first speaker, Professor world-renowned dignified fertility specialist, Professor M. Lewis Hall. She leads the endometriosis group and fertility and conception team at the Robinson Research Institute, and she is the deputy head of department, University of Adelaide. Her group is specialization in the application of digital technology to health promotion and delivery for people with endometriosis, technology, genomics, reproductive immunology, and novel mouse methods. Professor Hall publishes widely and present at international conference. She supervised PhD students and teachers, reproductive medicine to the medical students register and her fellows. She receives numerous grant fellowship and award, and she chaired on ASPARC Scientific Advisory Committee and ASPAR's Australian Committee representative. She is an international ambassador for World Endometriosis Society, and we are very happy to know that she is the owner and medical director of Embrace Fertility Clinic in Adelaide. She also sees reproductive medicine patient at her Women's and Children's Hospital at Adelaide. I would like to request Professor M. Lewis Hall to present her presentation. Respected Professor M. Lewis Hall.
Thank you so much, Dr. Bari, and also thank you, Maruf Siddiqui, for inviting me to present at this conference. It's been wonderful to hear some of the speeches already. The topic that I've been asked to present is called polycystic ovary syndrome in ART, and it's quite a broad topic. But I want to give a bit of an overview, but also to look a little bit more at how we might improve the things we do when we work with people with PCOS. And first of all, I think it's important to just talk about the definition, because polycystic ovarian syndrome is very consistently seen across most populations in about 5 to 20% of people. But the criteria is of a syndrome. So people can actually, if they have the symptoms, they can be in the diagnosis. And this is actually Posh Spice here. And she had polycystic ovarian syndrome. However, if you change your weight and you change your metabolism, you can fall out of the diagnosis too. And we all know women who have been able to change their metabolism in a way that they can ovulate, and then they really don't qualify for the syndrome. So we have to be careful how we define it. And the Rotterdam criteria is the definition we use, where we would say that you have to have 2 of 3 symptoms of either oligoamenorrhea or and ovulation, but clinical or biochemical hyperandrogenism, and polycystic ovaries on an ultrasound scan. And you have to exclude all the other causes. But I think it's also important to realize that when you actually test for hyperinsulinism, about 70 to 80% of people with PCOS have high insulins, particularly if they have a high BMI. Now, there's a fantastic article in Nature Medicine Disease looking at the biology of PCOS. And one of the things that people with PCOS have are increased intensity and number of LH pulses in the hypothalamus. And because there's no progesterone inhibition of these GnRH pulses, you get a lot of LH pulses that are increased in number and intensity. And so you get quite a high LH to FSH ratio. This high LH then induces the theca in the cells around the egg to produce a lot of androgens. And the theca has enhanced responsiveness to insulin. So if you have high insulin, the androgens increase even more. And also hyperinsulinism reduces sex hormone binding globulin production in the liver, which increases the free androgen index. So the androgen levels become higher and higher, and that's potentiated by hyperinsulinism. The third thing that happens is that you become anovular. And what happens is that there's insufficient FSH compared to LH to stimulate the follicles. So the high levels of LH stimulate the small antral follicles, which produce most of the AMH. And AMH prevents you from using all your eggs up at once. It holds them. And so these large numbers of small antral follicles that can't progress to late antral follicles produce a lot of AMH. So we see very high AMH levels, and we see lots of these little follicles around the edge of the ovary. When you get high AMH levels, FSH and aromatase don't work very well. So it's quite hard for us to stimulate the ovary as well, because we have to get above the FSH threshold, which is set high if there's lots of androgens around. And you can end up having either an under response because your dose is too low, or an over response. And you can find that you suddenly get 20 eggs. And so it can be really quite hard to stimulate because of that high set point. What we're increasingly wondering is whether PCOS is a metabolic disease with reproductive consequences rather than a reproductive disease. And I think increasingly we're wondering if insulin resistance and issues with sugars are more at the core of PCOS. And certainly there's quite a bit of work done in Adelaide looking at modelling what comes first, high insulin or the metabolic syndrome. And quite a lot of the time, people are thinking there's now insulin can be high set as an inherited factor from your family to predispose you to PCOS and predispose you to metabolic disorder. And the outcome of that is that you have behaviours that predispose you to putting on weight and storing food, which in lean times is a good thing to do. But when there's a lot of calories in your environment, it isn't so good. So the symptoms, if you have high insulin, and increasingly we're thinking that's often inherited, are fatigue, but you also have constant hunger. Because if your insulin's set high, it pushes sugars into your cells very quickly, and your blood always feels like it doesn't have sugar in it. So you get sugar cravings. It's also very hard to mobilize sugars if your insulins are high, because you can't get them out of the cell. So it's very hard to lose weight. So people go on to very stringent diets and they still won't be able to mobilize sugars out of their cells. But you also can get migrating aches and pains, often in the calves. And quite commonly, if you ask, people will have a strong family history of diabetes, or a family history of diabetes, or sisters with PCOS, or family members with gestational diabetes. Now, diagnosing insulin resistance is really difficult, except we do have some clinical signs, and one of them is acanthosis nigricans. And if you can look at this picture here, this dark shadow around the neck here is essentially due to hyperinsulinism. So the pediatricians use that as a marker to start metformin in young women with PCOS now, because what it's been shown is that diet and exercise alone doesn't really give you a long-term weight management program. But when you actually add metformin in, there's a long-term benefit to women, to adolescents with PCOS in terms of weight reduction and health and long-term outcomes. So a lot of this is now coming down to a different paradigm in how we see insulin resistance. And what we know insulin resistance is that even though there are very high insulin levels, cells won't take up the glucose very well. And we've always thought it's been a kind of starvation paradigm where the cell doesn't have much sugar in it. It's all not being able to go through the receptors. And increasingly, we're thinking it's more like an overflow. And this is why people get diabetes quite late in their life, and why we don't see diabetes in our young population. We see high insulin, not diabetes, because it takes time to fill your cells up with sugar to the point where they can't put any more in. And once you can't put any more in, you start getting sugar in your blood and you get glucose intolerance. And after a while, you get diabetes because it's there all the time. And the way to help people with insulin resistance is to lower the insulin, not to give them insulin. And if you can lower the insulin, it allows the sugars to come out of the cells. You don't have as many sugar cravings, and it can really change how you can control your weight and diet. And you can kind of not have to go into such extreme measures as a young, adult. Is it worth knowing that in our patients? And I think it really is. And it's very hard to diagnose, and sometimes acanthosis nigricans isn't present. But what you can do, if you do a 2-hour glucose tolerance test and add insulins in, most young people will sit in this area with insulin resistance, where the sugars aren't that high, but the insulin is very high. And we think an insulin over 60 merits treating with metformin at the moment. Eventually, over time, and you may well see it in your population, the sugars start creeping up and people can't maintain the insulin at that level. And then eventually you have high sugars all the time, and that's diabetes. But it's a spectrum. And the good thing is, I do think that you can go back down on that, go back the other way on the spectrum. But it is really important, because when you look at miscarriage clinics, and this is one that was done, this is a study done in Adelaide, where 170 consecutive patients had a preconception GTT with insulins. 54% had normal insulin glucose, and only 3% developed diabetes in pregnancy, whereas 46% had hyperinsulinism or glucose intolerance, but not diabetes. And out of them, 40% developed gestational diabetes. So if we know someone is hyperinsulinemic before they become pregnant, we can actually tell our obstetricians to really look out for them in pregnancy and watch out for gestational diabetes, because they're at much higher risk, and that can be really helpful for their pregnancy. So should we be doing this first? And I think this is the question. I'm going to try and give you some evidence, because I think we should, and I think we should be thinking about how we can do this a little bit better. Because we do have treatments to treat hyperinsulinism, and diet and exercise is actually really difficult to do if your insulin's very high. You don't mobilize your sugars well, you tend to be putting sugars in, and you're trying to do that while you've got sugar cravings and cravings for carbs because of the way your metabolism is set up. But it is important to do diet and exercise, but it's much easier to do if you do have some help with insulin sensitizers. And I think certainly in adolescent gynecology now, we're tending to use metformin for younger people to help them with that. And certainly in Australia, the naturopaths very much look at using myoinositol and chiroinositol, and I think they work as well too, although we don't have quite as much published literature on them. The other thing that lowers insulin very effectively is bariatric surgery. And so some people do choose that, particularly if their BMI is very high. The difficulty is if you choose bariatric surgery for fertility, you can end up, you have to wait a year before you can try and have a baby. And if you do that when your ovarian reserve is low, it can be very difficult. And you may need to freeze eggs or something like that. Just looking at the metabolism, and this is work by Hannah Brown at the University of Adelaide. When you have high insulin and high sugars, there's a lot of glycosylation in the cells, and you can see the difference between cells that are not exposed to insulin and glucose and cells that are. And these enzymes are very upregulated to do with sugar metabolism, and the enzymes get a lot of sugars attached to them, and they get very glycosylated. So they don't move very quickly, and you need a lot more energy to move your enzymes around in your cell. And that creates increased ATP and oxidative stress and free radicals in the cell. So then you have to upregulate all your protective mechanisms as well. And in the egg, you also find that your epigenome changes. So the epigenetics change when you're exposed to insulin and sugars. And just insulin, when you have high sugar on its own, you get a small change. When you have high insulin on its own, a small change. But when you put them both together, it's a big change. So we are potentially impacting on the genome by not treating. In terms of ovulation induction, metformin didn't feature as a first-line agent to get the egg out of the ovary. And medications that increase FSH secretion from the pituitary are much better to induce ovulation. And when you compare clomiphene to letrozole, and this is a network meta-analysis by Rui Wang, again from Uni of Adelaide, in Human Reproduct Date, they showed that letrozole was better than clomiphene at enhancing live birth rates, and that was quite significant. And then also clinical pregnancy rates, and it definitely reduced time to pregnancy. So letrozole is the first agent of choice, according to the published literature in this analysis, which has been done at quite a high level. What they did find was that metformin, when you compared clomiphene to clomiphene citrate and metformin, was very close to being significant in the numbers of in the 8 RCTs. And you can see that the confidence interval lies between 1 and 139. So they've said that it might improve clinical pregnancy rates compared to Clomid on its own, and it might reduce time to pregnancy. And they just didn't have enough data to suggest significance for live birth rates. So certainly metformin may be beneficial to help you induce ovulation induction. And the one thing it does help is it helps you with your dose responsiveness. So if someone changes their insulin levels while you're trying to induce ovulation, a dose that might work in one cycle won't work in the next cycle. Or a dose that worked where you got 1 egg once suddenly results in having 5 eggs and you have to cancel your cycle. And that's where metformin can help, because I think it helps you have a more consistent dose response because the insulin levels aren't changing depending what you're eating. The second thing is that the uterine tract changes also when you have a high insulin environment. And this is again Hannah Brown's work, looking actually at the lining of the womb. And this is more about implantation and miscarriage. And this very much shows that the lining of the womb in high insulin and sugar environments ends up having a lot of the enzymes being glycosylated again in the cells. There are much higher levels of inflammatory markers, and you actually get small placenta. So it has a direct effect on the placenta with high insulin and sugar environments. And we're increasingly thinking, again, that that's the insulin. And this is a study from America in 2019, where they cultured trophoblast cells in the lab. And they found that there was a huge increase in DNA, markers of DNA damage expression. a huge increase in apoptotic markers, and a very large reduction in cell survival when insulin was exposed to the trophoblast. But when you actually added back metformin, it prevented these things. And certainly metformin at the time of insulin exposure was beneficial, but when you added it with pre-treatment of metformin, the placental cells did much, much better in the lab. So again, it looks like it may help the placenta. We do know that polycystic ovarian syndrome impacts on miscarriage, and the miscarriage rates are about 12 to 13% higher in PCOS. But this really great study by Wang et al. From China showed, and in 2016 showed that it wasn't due to the chromosomes. So this was an implantation effect, not a chromosomal issue with the embryos. And when you had a miscarriage with PCOS, only 28% had chromosomal disturbance, but even though you were getting many more, whereas non-PCOS miscarriage had a very high rate of chromosome anomalies. So it appears that it's more the metabolic environment that's impacting than the chromosome environment. There is some data. This is a meta-analysis that's published in a Canadian journal, where there's really haven't been many randomized controlled trials looking at early pregnancy loss and metformin use. And that's often because people want the metformin when they have had recurrent miscarriage. The data is not very good because there were only about 30 people and only one loss. When you look at the non-randomized trials, it appears to be much clearer that there's a benefit, but I don't know that we can say very strongly that we're sure about the impact on early pregnancy loss. And I think at this point, we have to say it may reduce the risk, but certainly there's evidence that that's a significant possibility in conjunction with the biological data. What is clear, though, is that when you look at the premature delivery, and this is actually often a really difficult situation for couples if they lose a baby in mid-trimester, or or have a very early baby. We often get damaged babies in this situation, and we can see that metformin does reduce the premature delivery in PCOS. So that's actually something that is hugely beneficial for people. And it's quite common when I see people who've had late losses, if we check for insulin, they've had undiagnosed hyperinsulinism. And I think it's something we should be looking at more for the mid and late trimester losses. In terms of managing cycles in PCOS, this is probably some of the trickiest IVF stims that you can do, I think, when people have a high BMI, high insulins, and very high AMH levels. And we're always balancing between not giving enough FSH and getting 1 or 2 follicles and having to cancel a cycle because the response has not been good enough, with just getting 40 eggs and then, having to figure out what to do then. And it is a really tricky stim environment. So I'm going to, this is kind of a bit more clinical practice and how we've managed it, but I think there are different approaches to it. And I think it's a very busy slide, but I think the first thing that's really important is that if possible, you want to try and use an antagonist cycle, because then you have the option to use a GnRH agonist trigger, which is going to reduce the LH stimulation of vascular development in the ovary. And when those blood vessels grow in to the corpus luteum, if there's lots of corpus luteum, as they grow, they're immature, they leak, you get a lot of fluid. If you can use your own patient's LH, it's short acting, they don't get that growth. If you have to use HCG, it's very long acting. So there are 2 ways of doing the stim, and you can start with a lower FSH and increase if needed. And I must say we've gone to starting high and dropping down. And the reason, for several reasons, but I'm going to just go through them. So when you start with a low FSH, it's much less risky because you're likely to get a small cohort. And it's probably worth it if you're not able to monitor that closely, or if you're working with a lab that isn't very good at freezing embryos, because if you're going to get a much better rate from a fresh embryo, it's probably better to have less eggs and be able to do a fresh transfer. But we're really getting much better at freezing, and most of our labs would give very similar rates with fresh and frozen. And the advantage of starting high and dropping down is that if you start low, you end up with cohorts that are different. You get a few eggs that are big, you increase the dose, you get some middle-sized cohorts, and you get some small ones. Whereas if you start high, you get the whole cohort growing. You have to watch like crazy and intensively monitor, but you can drop down to get rid of the small ones. But you do need to be able to freeze if you get a lot of eggs. I think in a low start, you're much more likely to cancel because you get small numbers and you come back later. You can't get the eggs to grow. You very much get a mixed cohort of eggs, and it's really, really difficult to know when to trigger, because you'll have some that are big, some that are small, or you'll get a lot that are at different sizes and you'll go too early. And often you'll have immature eggs. With the high stim, you're likely to freeze all and you're less likely to cancel. You tend to get a similar egg cohort, and it's much simpler to know when to trigger. You do get more mature eggs, but some will still be immature. I think in a low stim, the issue is you may not realize how high the estrogen is because you've started low, you've got to a trigger, and you haven't got that many eggs because a lot of them have been triggered too early, and you're at risk of putting one back and then getting late onset hyperstim in a pregnancy. Whereas with the high stim, you're much more likely to get early hyperstim, which is quite easy to manage, but you're much more likely to decide to do a freeze-up all appropriately and not be tempted to put that embryo in. So it's much easier to see you've got way too many because they will come out of the follicles. So I think there's two different ways of doing it. We're certainly moving a bit more to the high stim and dropping down, but I think the choice is a little bit dependent on what kind of lab you have and whether you can do freeze-alls and you feel like you've got enough monitoring that you can be very careful in around the time of the pickup with that early hyperstim. One of the things that we wonder about, does metformin improve pregnancy rates in IVF? In 2009, the Cochrane review did not find there was an effect on pregnancy rates with metformin in IVF, but in 2016, more studies had been done and that effect was shown in the Cochrane review. So we do get a higher clinical pregnancy rate, but we've not reached enough level of certainty over the live birth rate, which obviously needs more power to be shown. But there is some evidence we get a better rate with metformin. And what is clear is that metformin does, in the long protocol where you're at high risk of hyperstim, metformin does reduce the risk of hyperstim. And that hasn't been quite so effectively shown in the short stims where we manage hyperstim so much better. I think it's absolutely critical that before you start IVF with a tricky PCOS person with a high AMH, you minimize the risk of hyperstim. And first of all, you need to know that they've got lots of follicles there before you start your stim. Okay, so you need to know the antral follicle count or their AMH. I would certainly, if you think they're hyperinsulinemic, be starting metformin, because it will make your dosage variability in the cycle much better, but also it reduces hyperstim. You need to make sure they know that you're going to do a freeze all if you get too many eggs and that's a risk, and just don't transfer if it looks like it's too risky. Carbergoline is a dopamine agonist that reduces VEGF production in the vessels around the ovary. So if you use that for a few days after the pickup, that's going to reduce your risk as well. But you do need to put close monitoring after the pickup if you're not putting an embryo back. If you are putting an embryo back, you have to know that you're going to be looking after that person at the time of the positive test and potentially need to be monitoring very carefully. And it's the late stim that causes the biggest problems. So it's important that you've got that in mind. So I'm going to kind of finish just saying, I think some of the things that we're changing in the way we practice is whether we're starting to think about whether to treat treat hyperinsulinism before we start treating people with PCOS. And many of them will conceive naturally if you do that. It really helps people manage diet and exercise and weight loss if they have hyperstim. And we know that in young girls. It improves your dose responsiveness to letrozole and clomiphene. You don't find one cycle, it's so different from another. You can have more consistency in your dosing. It might improve the clinical pregnancy rates in OI, and that's from Rui Wang's work. And it might reduce the time to pregnancy. And again, that's from his work. It certainly identifies people at risk of gestational diabetes so we can let our obstetricians know. It might reduce the risk of early pregnancy loss, but it does reduce the risk of premature delivery, and that's quite important. It does improve the clinical pregnancy rates in IVF, and it reduces the risks of hyperstim and GnRH agonist cycles. So I think there's increasing evidence that this is something we should do before we start. And hopefully we can set up our cycles and our practices so people get to the point of being able to conceive more quickly and more safely when they have PCOS. I'd like to acknowledge some of the people I work with in Adelaide who do a lot of, there's a big consortium on PCOS here, and Dee McCormick, Hannah Brown, Lisa Nicholas, Rob Norman, Alexia Penner, and Sarah Robertson all work in this field and have been enormously helpful for both my practice, but also my understanding of PCOS. So thank you very much for having me, and I hope that's been helpful.
Thank you so much, Professor Hull. It was really a brilliant presentation, and I think your well thought out solution will help us to treat this woman with polycystic ovarian syndrome and also the scope of ERT. And so many research experience of your own study will help us in your clinical practice too. Thank you again. Now, I would like to invite our dynamic, brilliant presenter, Dr. Nusrat Mahmood. She is the Associate Professor in the Center for Assisted Reproduction Care, Department of OBGYN, Bardem General Hospital, and Ibrahim Medical College Hospital at Dhaka. And she completed her Master's in Reproductive Medicine and Endocrinology from National University of Singapore. And she is the Honorary Research and Clinical Supervisor in Rollins School of Public Health, Emory University, Atlanta, Georgia, USA. She is the country representative of Bangladesh in Aspire since last 8 years. And we are really very proud of Dr. Nusrat Mahmood. And she is the Secretary of International Affairs, Fertility and Sterility Society of Bangladesh. She is the Joint Secretary of Gynecological Endoscopic Society in Bangladesh and Scientific Secretary in Endometriosis Society of Bangladesh. She is the Organizing Secretary of Polycystic Ovarian Syndrome Club Bangladesh, and she is the Course Coordinator in Bangladesh Institute of Minimally Invasive Surgery. And we are really proud to say that she is the Associate Editor of Bangladesh Journal of Fertility and Sterility, and she is the Member Editorial Board of Bangladesh Journal of Obstetrical and Gynecology Society. And we are very lucky that she is the executive member of formulation of national guideline in the management of infertility in Bangladesh. And she keep our name and fame as a invited speakers in many reputed international and national scientific meeting. Respected Dr. Nusrat Mahmood, I would like to request Dr. Nusrat Mahmood. Yes, okay. Thank you.
Assalamu alaikum and very good afternoon. This year, we are celebrating the golden jubilee of our independent Bangladesh. And in weeks' time, our victory day is here. 20 years back, a couple of visionary personnel conceived the idea of formulation of Fertility and Sterility Society of Bangladesh. I salute them for their vision and their foresightedness. Thank you, the organizer, for giving me a chance to talk in Fertility and Sterility Society's 6th International Meeting. PCOS is a spectrum of diseases range from reproductive changes, metabolic changes, and psychological changes. Today, I'm going to talk on the insight of management of PCOS with infertility. If we go into the depth of pathogenesis of PCOS, we can see there are genetic preponderance, superadded lifestyle changes, and environmental factor, which causes the epigenetic expression of the disease. And there are controversies regarding the diagnostic criteria of PCOS. But for now on, the Rotterdam Consensus is now firmly grounded as the best evidence criteria for diagnosis of PCOS. And it is accredited by the American Society of Reproductive Medicine and European Society of Human Reproduction and Embryology. Dr. Lucina Suarez has done a retrospective birth cohort study between those patients who were born between 1973 to 1975 in a single maternity hospital, and she interviewed this person in their adulthood between the age of 27 to 34 and regarding their symptoms of PCOS in a questionnaire. And depending on that public health study, she could find out the prevalence of PCOS about 9% if we consider with NIH group, and American and European Endocrine Society diagnostic criteria could be 10 to 12%, and in Rotterdam criteria, it's 12 to 18%. So in general, the prevalence of PCOS is quite high in reproductive age women. If we see the world data, there are ethnic, geographical, and racial variation of PCOS, and it varies from ranges to ranges and region to region. It is common in South Asian women, and there are high prevalence of insulin-resistant, metabolic syndrome, and type 2 diabetes, and high central obesity. In contrast to the Mongolian races, where we see there is a low expression of high androgen, that is hyperandrogenism features of clinical manifestation compared to that of Caucasians and South Asians. So before treating the patient on clinical basis, we need to have evidence-based guidelines. If we elaborate what is evidence-based guidelines, it are mostly generated or formulated by the research from evidence, clinical expertise, cost effectiveness, and consumers' perspective. My today's presentation is based on evidence-based guideline, how to manage the PCOS with infertility. If we recapitulate our reproductive physiology knowledge in our basic medical school, we know the ovulation and menstrual cycle is a hormonal play or play of hormones. In other words, it's a harmony of hormones. Spike of FSH and LH secretion from pituitary gland and hypothalamus causes popping out of mature follicles that we call ovulation. And anovulation is a challenge and major challenge for managing the PCOS patient. This is a schematic diagram of based on the evidence-based management for the treatment of PCOS with infertility. I must confess that few of my slides might be overlapped with my previous speaker, Dr. Louise Hall. She explained very nicely regarding the treatment of PCOS with ART. We are talking in the same subject in a bit of different spectrum actually. So overweight and obesity is a major concern for infertility because the obesity is cause the anovulation to this patient. We have to keep in mind also that the obesity shouldn't be the diagnostic criteria for PCOS because there are lean PCOS too. And insulin resistance is not also a diagnostic criteria for PCOS. And metformin is not a weight reduction drug. We randomly use metformin for the reduction of weight, but we have to keep in mind that weight reduction is metformin shouldn't be used and not recommended for using weight reduction. 50 years back, Maven Taylor, Dr. Maven Taylor is a Harvard faculty. He discovered first the medical drug for ovulation induction, that is clomiphene citrate. Interestingly, his daughter, the Julie Tamer, she directed The Lion King, the musical version of Lion King, which awarded 6 Tony Awards and is a magical musical soiree. And the magical drug is introduced by his father, the clomiphene citrate. We know clomiphene citrate act by depletion of endometrial receptor in the pituitary and hypothalamus, and it has effect on the cervical mucus too. It's a safe drug since used for first line of treatment since 55 years, and have good ovulation rate and pregnancy rate, and it's safe, but there are some major drawbacks. Since 1990, there are a need for options for other ovulation-inducing agent, as the clomiphene citrate has a few major drawbacks for ovulation-inducing induction. And Robert Casper and Mohammad Bitawali of Toronto General Hospital, they offer and propose the concept the idea of sharing the in ovulation-inducing agent aromatase inhibitor instead of clomiphene citrate. And in 1990, they have done a pilot study using the letrozole, the non-steroidal reversible aromatase inhibitor for ovulation induction instead of clomiphene citrate. And they published their pilot data of pilot study in 2000, and it shows it gives a very good result as an ovulation-inducing agent. The major concern was because letrozole act by conversion or by blocking the conversion of androgen to estrogen, there could be a high level of androgen and low level of estrogen. But interestingly, the plasma half-life of letrozole is very short, that is 48 hours. It's eliminated from the body. It's a short-acting drug, and it's a reversible aromatase inhibitor. So it can be, it is not accumulating in the body for a long time. So letrozole ensures the improved endometrial thickness. It has higher pregnancy and singleton pregnancy rate. Badawi and his team has done a study using the extended letrozole therapy from day 1 to day 10, and they have shown the higher number of patient ovulates, number of dominant follicles were more, and pregnancy rates were significantly greater compared to that of gonadotropins, no extra cost. And again, then Mitawali and his team recently published a study with letrozole as a low-dose step-up protocol where they have used letrozole from day 2 of the menstrual cycle up to and increased the dose accordingly from day 2, 3, 4, and 5. And they have shown there is a very good multifollicular development and higher pregnancy rate. The concern was the safety of the drug and other major congenital anomaly. And there was a study, meta-analysis of the concept study, where they have done 3 studies in polycystic ovarian syndrome with clomiphene-resistant group and the safety study, and published in New England Journal of Medicine, where they have shown that among 750 US women, one arm they have given clomiphene citrate, and in another arm they have given letrozole, and it was a double-blinded multi-center study. And the efficacy variables was primarily the pregnant live birth rate, and secondarily ovulation, singleton pregnancy, and pregnancy loss, and any congenital anomaly. And they conclude their study was saying that letrozole was associated with higher live birth rate and ovulation rate, and it's safe for PCOS patient. Still then, there was controversy regarding the congenital malformation, and Tulandi and its team has done a study about among 911 newborn conceived after treatment with letrozole, and analysis was done to see the congenital malformation, deformity, or chromosomal abnormality regarding the major and minor malformation, ventricular septal defect, or cardiac malformations. They conclude their study that the concern that was letrozole used for ovulation induction could be teratogenic is unfounded and based on their data. Recently, they have the same group, the Tulandi and Tusami from Japan, they have done a study. They have done a retrospective study of Japanese, from the study was taken from the Japanese National ART Registry and published in Human Reproduction, where they have seen the pregnancy outcome regarding the miscarriage rate and live birth rate and ectopic pregnancy and other abnormalities. And they have shown, and they conclude their study by saying that there is no major congenital abnormality, no adverse pregnancy outcome, and no adverse neonatal outcome using the letrozole in polycystic ovarian syndrome. So it can be concluded that the letrozole is the safest drug and time-tested first-line treatment nowadays for the treatment of polycystic ovarian syndrome with infertility. We have done a study among our Bangladeshi population and was published in the Folk Journal, and we also conclude that oral administration of letrozole is an effective agent for polycystic ovarian syndrome. It's cheap, easily available, and less side effects. Metformin, it's a magical drug everybody used randomly for weight reduction, but it shouldn't be used and recommended for weight reduction. It is only used where there is impairment of glucose tolerance, where there is a family history of diabetes, or where there is a family where there is a high insulin resistance among the patient with PCOS, and it should not be used as weight reduction agent. Other adjunct therapy like myo-inositol or D-chiro-inositol, these drugs are cheap and widely available, relatively lack of trials, but Cochrane studies have shown a positive result, but much more studies should be needed. But before giving the ovulation induction, we have to think about that the weight reduction of the patient. The obese patient should need to reduce their weight to up to a maximum, up to their maximum upper limit, acceptable limit, and we have to postpone start the ovulation induction after bariatric surgery, because the past rate of weight reduction should be eliminated. Then we should start the ovulation inducing agent to this patient. We have to exclude the other causes of infertility and hyperandrogenism before giving ovulation-inducing agent. And also we have to treat the hypothyroidism and hyperprolactinemia before starting ovulation induction. FSH is very important and for follicular genesis and follicular recruitment. There are waves of FSH secretion that causes the development of follicle, we know. So if we want to introduce FSH for the treatment of ovulation induction, we have to start early. The exogenous FSH should be started from the early phase, that is the recruitment phase. There are a lot of gonadotropins available in the market, both produced internationally and nationally. Urinary FSH, recombinant FSH, recombinant FSH-LH, and also the human menopausal gonadotropins. But we have to keep in mind that human menopausal gonadotropin is not the choice of drug for ovulation induction in cases of PCOS patient, because human menopausal gonadotropin contain FSH and LH. In PCOS patient, there are high LH levels. So if we give exogenous LH to this patient, there will be growth spurt, there will be a lot of immature follicle without any effective mature follicle for ovulation. So FSH is the drug for gonadotropin protocol for ovulation induction. There are different protocols. The step-up low-dose protocol, where we start a half dose, that is 37.5, and increase the dose up to 50% depending on the monitoring result. And it has been seen that it gives a good result. Step-up protocol, that is fixed dose started from 75, and starting dose should be adjusted according to the BMI of the patient. I'm not going to talk into the detail because my previous speaker has already mentioned these protocols. There are sequential protocols where there's alternately high and low dose is used till the maturation, and they have seen that 56% of mono-ovulation rate and low OHSS incidence has been seen by using the sequential protocol. If we compare the step-up and low-dose protocol, there's a study which has shown that the data from 225 women with PCO for 300 cycle, and they have shown the pregnancy rate was high in low-dose step-up protocol, and multiple pregnancy and ovarian hyperstimulation syndrome was less in this group of patients. So if we compare the regime and efficacy of ovulation induction in PCO patient, we have to think that we have to keep in mind that endpoint of giving ovulation induction is have to have a monofollicular development. We have to keep in mind to avoid the multiple pregnancy. We have to avoid the ovarian hyperstimulation. We have to think about the miscarriage rate, and we have to think about the social. We have also the social responsibility, that is, we have to deal with the healthcare economic status of a patient and financial burden of the patient. So we need to have developed a monofollicular development by choosing the regime and efficacy of ovulation induction for the patient of PCOS. In case of IVF, it has been shown that antagonist protocol is better. It is cost-effective, better control over induction, and reduce ovarian hyperstimulation rate, and good for poor responders. Laparoscopic ovarian drilling is there are controversies dealing with that, because the best part is laparoscopic ovarian drilling is the choice of patient where there are patient is the AMH level is high and insulin resistance is high. This group of patients get better result by using laparoscopic ovarian drilling. The advantages are there is no need for intensive cycle monitoring, no need for gonadotropin stimulation. So there's, compared to gonadotropin stimulated cycle, there will be less expensive this laparoscopic ovarian drilling protocol, laparoscopic treatment modality. But there are adverse effects too, because laparoscopic ovarian drilling is a surgery. There is a risk for premature ovarian insufficiency. There are risks involved with the surgical skill. There are risks involved with the general anesthesia. And some patient get benefited, but 50% gets benefited, and 50% may need after laparoscopic ovarian drilling additional ovulation-inducing agent. So wide range of treatment options are available for treating the patient with polycystic ovarian syndrome with infertility. Some patients get benefited from one treatment, some may not. So the patient-tailored approach is the best protocol. That is, controversies are treatment with infertility with PCOS is surrounded by many controversies, and more patient-tailored treatment approach needs to be developed for ovulation induction based on patient initial screening, individual characteristic of women with PCOS, which reduce the development of ovarian hyperstimulation and multiple pregnancy and reduce the burden in health sector. This is my favorite slide because in 1978 is the year of many scientific innovation. The Nobel Prize was awarded for the discovery of cosmic microwave radiation. Sony invented the first portable stereo Walkman, and we all enjoy in our childhood. The very first online exchange forum, the blog and social media, was debuted in Chicago in 1978. The best thing happened in 1978 is the birth of first test tube baby, the Louis Brown. Since then, the treatment of reproductive medicine and infertility are not the same as before. Sir William Osler was right. He could sense in 1892 that if it were not for the great variability among individuals, medicine might as well be a science and not an art. And there comes the era of precision medicine, that is precise medicine, depending on the genetic and metabolic data, biological changes, behavioral changes, and proteomic criteria that is given and that produce the drug for the ability to offer a right drug for the right patient for the right disease at the right time. And the best example is we tell and we repeatedly request our patient to reduce weight by caloric restriction in PCO patient. But the best example is hippo. The hippo runs after miles and miles and only eat the green grasses, and he couldn't reduce its weight. So that is impossible to reduce weight by eating green grass, salad, and walking. There must be something, that is the genetic, environmental, and proteomic factor that identified and that differentiate individuals. So there lies the art of precision medicine, and it has impact on polycystic ovarian syndrome too. And the great mind thinks alike. Albert Einstein could sense and could quote that if you want a different result, do not do the same. So the era of precision medicine and for the treatment of infertility and PCOS is here. We have to utilize this groundbreaking technology for the benefit of our patient. We have to aware for the PCO, we have to need to build up a PCO awareness group with the involvement of stakeholders, NGOs, and government sector to make our reproductive age women understand that this is a very long-term disease and we need to treat this patient early. And the PCOS infertility is interesting to treat because this patient gives good result by giving just a couple of medications and weight reduction and certain magical drugs. My presentation was based on international evidence-based guideline, and I treat my patient with PCOS with infertility according to the guideline of international evidence-based. And I also use patient-tailored treatment, and hopefully we will be get benefited with your experience, expertise, and I thank all the contributors who formulate the international guideline and recommendation for evidence-based assessment and management of polycystic ovarian syndrome. Thank you very much.
Thank you so much, Dr. Nusrat Mahmood, for your nice and brilliant presentation, and especially your scientific sharing was very important, and we actually really amazed to hear some philosophical talk from your lectures. Thank you so much. Now I'd like to request our another legend in the field of fertility in our country. She is Professor Mariam Faruqi, and she is a senior consultant, gynecology and obstetrics and infertility specialist at Labit Specialized Hospital and Hope Infertility Center. She is our Secretary General of Fertility Preservation Society of Bangladesh, and she is advanced training. She got her advanced training in assisted reproductive techniques in Korea and India. She has several national and international publications, and we are really happy to see Professor Mariam Faruqi to have us among us today. Professor Mariam Faruqi.
Thank you. Am I audible, Sumaya?
Yes. Yes.
Thank you very much. Thank you very much, Sumaya, and respected chairpersons. Good day, salam, Vijay Mashu Shubhetsha, and also welcoming to moderators, reporters, all the speakers, and my colleagues. And my heartful thanks to the organizers, especially heartful thanks to Dr. Maruf. Unless his so much hard work, this session or this whole international conference will not be a success. Thank you very much. My paper is on genetics and male infertility. Next. আমি করব আচ্ছা এটা দিলে হবে না এটা হবে আচ্ছা this evening this subject may be a bit boring maybe but
can you make it in full screen?
Okay,
you please make it in full screen view. Yeah,
full screen.
Yeah,
I think Farzana Poppy is there. Poppy,
ma'am, you are sharing the
iconটা
slide
চাপ
from
দিলে চলে
your
যাবে
laptop.
যা যাবে মানে ফুল স্ক্রিন
নিচের দিকে একটা কাপের মতো আছে, দেখেন একদম নিচের লাইনে ডান দিকে একটা কাপের মতো আছে,
একদম নিচে,
একদম নিচে।
হ্যাঁ, এই যে তিনটা বাটন আছে একদম
বাটন মোর এই যে মোর। আচ্ছা, ওকে,
জি
ক্লিক করতে হবে আপা। যে 69% লেখা আছে তার পাশে যেটা, ওটাকে আপনি ক্লিক করেন।
পারছি না না
আপা, জাস্ট এটার উপরে 69% এর এই পাশে আপা,
69% তো পাচ্ছি না।
এই যে নিচে আপা, একদম নিচে।
আচ্ছা,
হ্যাঁ, এই যে নিচে
দিলাম।
আপা একটু বামে আসেন, বামে আসতে থাকেন, আর একটু
হ্যাঁ হ্যাঁ
ক্লিক করেন।
ওকে, থ্যাংক ইউ। এখন কি আমাকে ইয়ে করতে হবে? Reproduction, my paper is on genetics and male infertility.
আপা এটার পাশেরটা ক্লিক করেন আপা, এটার পাশেরটা। আপনি মাঝেরটা ক্লিক করেছেন তো, রাইট সাইডেরটা, সরি লেফট সাইডেরটা।
নিচে আবার আসতে হবে।
না না, ওখানেই আপা, জাস্ট তার পাশেরটা,
এখানে তো নাই,
যেটা ক্লিক করা আছে আপা তার পাশেরটা।
এখনো হয় নাই?
হ্যাঁ, এবার হয়েছে, এবার হয়েছে আপা।
ফাইন আপা, গো অন।
তুমি চলে যাও, আমি অনেক আগে চলে গেছি, সামনে যেতে হবে তো। হ্যাঁ, আরো সামনে। তারপর আমি কি এটা টিপলেই হবে? এইটা টিপবো? Reproduction is a highly complicated process, and all these processes are regulated by a number of genes and require proper functioning of these genes. Infertility, we all know that is the inability to achieve pregnancy, which with after getting full opportunity for about 1 year. Causes of infertility varies, and nearly 30% of cases are due to genetic defects. Genetics contributes to infertility by influencing variety of physiological processes like hormonal homeostasis, spermatogenesis, and sperm quality. Why genetics is important? Because genetic disease means abnormality involving genes and chromosomes. Abnormality may be missing a piece of the chromosome or changes in the DNA sequence, genes in the DNA sequence, or changes in the total number of the chromosomes. So why we think of genetics? Because in this era of ART, ICSI allows suboptimal sperm quality to overcome the natural selection mechanism to form a viable zygote. And IVF, ICSI, these are new procedures, and the inheritance of mutation through these procedures and their impact on future generations are not yet fully understood. So in this era of complete genome mapping, personalized treatment is coming to forefront. Many aspects of the molecular basis of infertility in human remains poorly understood. Applications of genetic knowledge in this field is also very much promising. Genetic causes of infertility are most common cause in male are Klinefelter syndrome, translocations, Y chromosome microdeletions, hypogonadotropic hypogonadism, X chromosome defects, CFTR gene mutations, trisomy 13, 18, 21, and epigenetics. Yeah, causes can be divided into 4 compartments. Like in hypothalamus, there are KL1 gene, the mutation of which may leads to hypogonadotropic hypogonadism. In also hypothalamus, AHC gene, whose mutation may cause congenital adrenal hyperplasia male. In pituitary, we have GnRH, hormone receptor gene, FSH beta gene, LH beta gene, and these are mutations of these are then phenotypically expressed. In gonads, there are genes involving genes whose mutation hinders the steroid synthesis. In X chromosome, it may be whole X deletions, 45X cell line with mosaicism, without mosaicism in female, which may lead to premature ovarian failure. In case of Y chromosome causes 46XXY, Klinefelter syndrome, or translocation, or there may be single gene disorders, SRY gene, this may lead, or azoospermic factor gene, which are very much renowned now. We are always hearing about azoospermic factor gene, and these are mutation in these genes results in different types of azoospermia and severe oligozoospermia. In the outflow tract, like androgen receptor gene mutation, there may be androgen insensitivity, patient may be female phenotype, and maybe azoospermic. And in case of CFTR gene mutation, there is cystic fibrosis disease, congenital bilateral absence of vas difference. In infertile men, 1 to 2% we found CFTR gene mutation, and here interesting is the obstructive type of azoospermia. So by testicular sperms are here immotile, and by TESE or PESA, we can retrieve the sperms from the testes, and ICSI can be done. So, but important is in CFTR mutation gene, we have to test the partner, female, and if the female is a carrier, there should be genetic counseling as chance of offspring is more to be CFTR carrier. And HOXA13 gene, only single gene known to cause uterine anomaly. And the laboratory technique which are done, investigations which are done for genetic disorders or chromosome analysis or karyotyping, and FISH or fluorescent in situ hybridization technique, PCR sequencing, PCR microarray, and next generation sequencing. Male fertility criteria includes normal spermatogenesis, complete maturation of the spermatozoa during passage through the accessory organs of reproduction, patency of the accessory organs, production of adequate volume of seminal fluid, ability to deposit sperm into the vagina, and mobility of the spermatozoa to reach the oocyte and penetrate it. And most frequent genetic basis of male infertility are chromosome abnormalities, mutation of the CFTR receptor gene, or Y chromosome microdeletion, and some familial autosomal recessive component. In Klinefelter syndrome, karyotype is 47XXY. Patient is usually infertile, decreased testicular volume. In azoospermic patient, 10% we found Klinefelter, and in severe oligospermia, 5% are found. But interesting that less than 8% have few sperms in the semen, and sometimes sperm can be retrieved from the testes. Here, LH gonadotrophins are increased, testosterone is decreased, feminine body constitution, gynecomastia may be present. Majority azoospermia with ART can father after successful ICSI. By TESA, MESA, we can, or focal spermatogenesis can be detected and sperm can be retrieved, or testicular biopsy, or TESI, or cryopreservation of the tissues may be options. In Y chromosome microdeletions, in Y chromosome, there are areas of interest in male infertility. It contains genes of spermatogenesis and gonadal development. Microdeletion involves several genes not detected by usual detected by normal karyotyping. Non-obstructive azoospermia, 10 to 15%, and severe oligospermia, 5 to 10%, we found microdeletions. Microdeletions in Y chromosome, there are areas in Q limb, long arm, we have areas A, B, BC, and C zones. Reflected in semen parameters, that is phenotype, vast majority deletions involve C zone. Sperms may be, if there is C zone microdeletion, sperms can be present and ICSI can be done. But deletions in A and B zone, their patient can with azoospermia, usually sperms cannot be retrieved. TESI can retrieve sperm in C deletion, microdeletion passes into the male offsprings. Another we know about the congenital bilateral absence of the vas difference. This is an obstructive azoospermia due to CFTR gene mutation. CFTR mutation leads to congenital malformation of the Wolffian ducts, which are seen in the absence of vas difference, epididymis, seminal vesicles. CVAVD patients exhibit azoospermia, decreased seminal volume, decreased pH, decreased alpha glucosidase and fructose. Here, hormone levels and testosterone are normals. Majority normal spermatogenesis can father a child after TESA and then ICSI. But risk of transmitting child is high depending on the CFTR mutations of man and the carrier states of the mother or woman. So PGD should be done to avoid affected offspring. And it is an autosomal recessive manner present in the chromosome 7. Next, in the translocation, most common is Robertsonian translocations. Can cause loss of genetic materials at breakpoints, disrupts the genetic message. Robertsonian translocation is the most common, and incidence is 0.8% in infertile men. Risk of passing it to the offspring, FISH is recommended with the sperm. In hypogonadotropic hypogonadism, decreased sex steroids and gonadotrophin levels, defect in GnRH from hypothalamus, and when it is present with anosmia, it's called Kallmann syndrome. Gene mutation of the GnRH secreting neurons, CAL1, it's also present in the chromosome 8 and also in X chromosome. Low steroid hormone inhibits sexual development and spermatogenesis. Direct gene sequencing or sequencing after mutation screening can detect this abnormality. But all these techniques demand time and mainly resources. So mutational analysis should be done after genetic counseling, which includes full definition of the symptoms. We have to find which patient will go for genetic testing, genetic counseling, and also identification of the familial cases, definition of the patterns of inheritance. So number of genes to be screened could be limited because it costs a huge money to do the all gene study. In the conclusion, we can say the genetic tests in male infertility are where it is indicated that in azoospermia or severe oligozoospermia in RPL, repeated implantation failure. Detection of genetic alteration will not change the treatment. Genetic testing should be performed for finalize the cause of diagnosis and to assess the genetic right for the offspring for successful treatment. Genetic and genomic abnormalities such as chromosomal aneuploidies, chromosomal defect, genetic mutations, and epigenic dysregulations can cause infertility in both male and female. Depending on the clinical findings, infertile male patient needs genetic evaluation, karyotype analysis, Y chromosome microdeletion screening in azoospermia and severe oligozoospermia to rule out Klinefelter syndrome, Y chromosome microdeletion, and also in couple with recurrent pregnancy loss. In obstetric azoospermia, CFTR gene screening, and in hypothalamic hypogonadism, mutation screening according to the clinical feature. Much work still to be done to determine the involvement of the genes in production of the phenotype. Accurate transmission of genetic and epigenetic information is essential in infertility. By global investigative approaches, interactions of genetic, environment, and ethical ground of fertility can be determined. With this knowledge, clinicians will be better able to treat infertile patients and make knowledgeable decisions about the use of ART. Information must be neutral and complete about all available options. The ethical aspects need to be addressed thoroughly. Each case should be an individual one. That is, treatment should be personalized or individualized with the advantage of advanced genetic testing like next generation sequencing. A genetic basis of reproductive disease can be identified. Expert counseling by a clinical geneticist should accompany every genetic test. Thank you all for patience hearing. Thank you, the organizers also, for giving me the chance to share this thought. Thank you.
Thank you so much, Professor Maruf Siddiqui. Actually, Professor Mariam Faruqi. Actually, we all know that nowadays the male infertility incidence is going high, and I think your updated and this excellent presentation will help us to treat such type of patient. Thank you again. Now, I would like to request our honorable chairperson of today's session to say a few comments on today's presentation and for the presenter. First of all, I would like to request Professor Begum Nasreen, Entertainment Secretary of OGSB, for her kind speech. Professor Begum Nasreen.
Thank you. Thank you, Dr. Sumia Bari. I first congratulate all the three speakers, Professor Louis Hull, Dr. Nusrat Mahmood, and Professor Mariam Faruqi, Madam, for their brilliant presentation. We learned a lot from their presentation. PCO is the most common cause of female infertility, and it is not only common, but we face different problem when handling this patient. PCO patient. Some patients are poor responders. Some patients develop ovarian hyperstimulation syndrome. Professor Louis Hall nicely described the pathophysiology of PCOS patient and how this patient develop hyperinsulinism, insulin resistance, and hyperandrogenism, and how they face difficulties to manage this patient, how these difficulties can be overcome, and she also shows different evidence, different literature review regarding the role of metformin in decreasing these complications. Regarding Nusrat Mahmood presentation, she nicely described that the role of different evidence-based guideline for the treatment of PCO patient. She compared the CC with letrozole in case of PCO patient and different gonadotropin, recombinant FSH and menopausal gonadotropin, and also the role of laparoscopic ovarian healing. The participant and we also all learned a lot from their presentation. Now coming to Morium Faruqi Madam's presentation, the genetic, she talked on the genesis of male infertility. I think the male infertility is the most neglected part of evaluation in case of infertile couple. We only do the semen analysis and tell them your semen parameter is not good, you have no hope, and we also think that there is no hope in this patient and that there is nothing to do. But evidence shows that a lot of things we can do. We can advise them, especially in case of oligospermia, azoospermia, and congenital absence of Haas difference. There is we can do the genetic testing. The most common problem in this patient, cystic fibrosis gene mutation, Y chromosome microdeletion, chromosomal translocation Klinefelter syndrome. Not only for them, for next generation, often when we see that there is obstruction, we do test SAPESA and ICSI. But if this patient have genetic disorder, the couple become pregnant, but if they pregnant and their baby, the next generation may suffer from the same genetic disease. So before doing the high costly ART procedure, we can at least counsel them that their baby may develop this type of genetic disorder. So they know that their next generation may suffer from this problem. And for this patient, counseling is very important in this cases before doing ICSI, TESA-PESA, and other advanced procedure. So I congratulate all the three speakers for their brilliant presentation. We learned a lot from them, and I thanks the presenter and moderator Sumia Baru for your nice moderation, and our rapporteur. And last of all, I thanks Dr. Maruf to give me the opportunity to chair the nice session in such important conference. Thank you.
Thank you so much, Professor Begum Nasreen, for your valuable speech and encouraging word for our presenter today. And now I'd like to request Professor Afroza Kutubi. Professor Afroza Kutubi, she is working as a head of the department in Sir Solimullah Medical College Hospital. Appa? Yeah.
Assalamualaikum. Good evening. Thank you for your nice moderation, Dr. Sumia Bari. And first of all, I'd like to thank the organizers of Fertility and Sterility Society of Bangladesh, who give me a privilege to be a part of this wonderful session. This was a very wonderful session. All the presenters talked very nicely. And I don't want to repeat those that are told by another chairperson, Professor Begum Nasreen Appa. But with the presentation of Dr. Hall, PCOS and ART, she nicely told us what is the important aspects of dealing a patient with PCOS in ART. And especially, we all know there is a high risk of ovarian hyperstimulation syndrome in patients with PCOS, where we should go them to treat them by ART. And she nicely told how we can use the antagonistic protocol with agonist trigger. And we can also use metformin for prevention as well as treatment of ovarian hyperstimulation syndrome. So her speech creates a new window about the use of metformin, not only for dealing with the metabolic abnormality, but it's a very structured consensus regarding reducing the premature birth, as well as improves the clinical pregnancy rate in patients with PCOS. Now about Dr. Nusrat. Nusrat is always a good presenter and she's a friend of mine. And the most important aspect of Dr. Nusrat Mahmood's speech is, I must mention the one line, every treatment should be patient tailored. And she nicely told, use of right drug to right patient at right time and right dose. And we, when treating a patient with PCOS, we must keep this word in our mind. And now regarding Professor Dr. Moriam Faruqi Appa, she is a senior Appa and always very popular to us. She nicely told about the genetics in male infertility. We all know infertility is increasing, and as well as there is increasing incidence of male infertility. And when some infertility cause regarding male factor was idiopathic, now with the advent of this modern technology, some of these can be explained. Many different modern technologies we are seeing in our neighboring countries like PGT, next generation sequencing, and the hope is that many of the genetic abnormalities, we can do surgical sperm retrieval and we can do IVF with ICSI so that we can give them a child in those couples. So I will no longer talk about anymore. I think all these lectures are very much beneficial and thought-provoking to our colleagues who are dealing with infertile couple as well as to our general OBGYN specialist. So I like to thank once again the organizers, my moderator, my rapporteur, and all the presenters. Thank you once again.
Thank you so much, Professor Afroja Kutubi, for your nice and encouraging words for us. And thank you. And now the session is open for question answer. And I think as we are already out of time, so I have to take one question for one speaker. First of all, I would like to request Professor Hull, there is a question for you. Is the PCOS patient on IVF and ICSI? Does myocytol increase the success rate?
I am not. I'm not sure. There is some work on it, but there's not as much work on it. But I suspect it has a similar effect to metformin in terms of it's an insulin sensitizer. So it's just there haven't been as many papers published, but I do think it would reduce the sugars out of the cells and potentially have a similar effect to metformin, but I'm not convinced that the studies have been done to show that as effectively as it has been done in metformin.
Okay, thank you so much. And there is another question for you. What is your tips when we will give stimulation in polycystic ovarian syndrome patients with poor responders?
With poor responders, it's tricky because you have to think that's where the long down regulation cycles can help if you know you're not going to get an over response. And again, if you get the metabolism right at the beginning, if you use a long down reg, there's pretty good evidence to show if you don't have many eggs that you may be able to bring them up together in a wee cohort and try and really use higher doses to get as many eggs as you can. So the previous speakers to me talked about some of the tricks, and the long down regs seem to help unless it's really low egg numbers. In that case, you can get caught out with long down regs, and it's better to pick a cycle on a baseline scan or something like that. Yeah, I tend to use the long down regs. I tend to use Testogel or testosterone. All the tricks in the trade of a low response, but we would potentially also use we normally test for hyperinsulinism, and again, if you can bring that down, it's going to help you with quality of the eggs and potentially better response to FSH at the level of the cell.
Okay, thank you so much, Professor Hull, for joining us and give such a nice answer of our question from the audience. And now I'd like to ask a question to Dr. Nusrat Mahmood. Appa, are you there?
Yeah, I'm here. I can listen to you.
Okay, so there is a question for you. Is there any association of stress or depression with the management of polycystic ovarian syndrome?
Yeah, of course, there's the psychological issue in PCOS. Moreover, when we manage patient with infertility with PCOS, there are always stress and depression among the patient and the couple. Number one, because due to lack of childness, and number two, the itself, the PCO causes depression and psychological manifestation. Yeah, thank you.
Okay, thank you so much. And there is a question for our last speakers, Professor Mariam Faruqi. You shared so many things about the male genetics, but at the same time, you also mentioned some controversy too, because what is the benefit of doing that male genetic test? As far we still know that there is no updated treatment for this correction or solution. So why should we go for, or advise for this male genetic test?
Because when patient come with, okay, I am azoospermic, I am severe oligospermic, why I am like this, or why there is RPL trigger or implantation failure. So he or she has the right to know her genetic abnormalities. That's why first and foremost for the diagnosis of the couple, whether he or she is suffering. Again, number two is it is the right of the offspring. When offspring is born with this type of defect, she might ask, or he might ask, why I am suffering from this. So for these two reasons, and also, so if we can make a diagnosis, there are options of treatment. Like this genetic disease, we can do PGD, and by PGD, if we can detect the abnormality, we can avoid this. So for these purposes, and in case of Klinefelter, in case of CFTR, there are also, so we can, if we can make a diagnosis, we can give our optional treatments. So that's why this is the right of the patient, this is the right of the offspring, and everyone to know what is he or she is suffering. And so they can father, or the female can mother a child. That's why.
Okay, thank you so much, Appa, for your nice explanation. And now, actually, we are already out of time. So I would like to request our Professor Maruf Siddiqui to tell something for this session.
We're running late, so just please wrap up the session.
Okay, thank you so much. Thank you all the audience and respective presenter. And now I'd like to request my rapporteur, Dr. Sanjukta Chaudhary, to continue the session. And thank you again.
Thank you, Dr. Sumia Bari ma'am, for your nice moderation. We have already approached at the end of this 11th session of day 2. I would like to extend my heartfelt gratitude to all who made the session successful, all the renowned speakers who made time to give their valuable remarks, valuable speeches regarding polycystic ovarian syndrome. I also like to thank our chairpersons, Professor Begum Nasrin Madam and Professor Afroja Kutubi Madam. And also I would like to thank all the participants who joined and make it a successful one. Now it is the power break for the Popular Pharmaceuticals who gave technical support for this session.
Please, thank you. Good night.
Thank you so much. It's been an absolute pleasure.
Yeah. Bhagire chala. Mashallah, alhamdulillah.
শুরু করো।
হ্যালো,
শুরু করো।
হ্যালো,
রাখি, স্টার্ট করো।
hello. Good evening, everybody. Respected chairperson, panelist, moderator, and learned audience. I, Dr. Rakhi Devi, Junior Consultant of Gynae Department, on behalf of Fertility and Sterility Society of Bangladesh, welcome you all in the 12th session of the second day of 6th International Virtual Scientific Conference. It is a great opportunity for me to be here. I am grateful to Professor Dr. Maruf Siddiqui sir for excellent team approach. Now I would like to introduce our chairpersons. Professor Brigadier General Hasina Sultana ma'am. She is a renowned gynecologist and professor of Obs Gynae Department, BSMMU, Dhaka. And Professor Samsun Nahar Lucky ma'am. She is a legend gynecologist, teacher, mentor, and excellent organizer of OGSB, and she is working as a head of the department of Obs Gynae Department, Khulna Medical College Hospital, and she is former president, Khulna OGSB branch. Today's topic of discussion is mixed bag scenarios with interactive panel discussion. Our moderator is Dr. Tanjim Sabina Chaudhary, Associate Professor, Department of Obs Gynae, Bardem General Hospital and Ibrahim Medical College, Dhaka. Now, with the permission of the chairperson, I request the moderator to conduct the session.
Thank you, Dr. Rakhi. Welcome everybody to the last session of this very successful conference. First of all, I want to apologize to Professor Brigadier General Hasina. There was a problem. She is actually the former professor and the head of the Department of Obstetrics and Gynecology, Armed Forces Medical College and CMH Dhaka. Sorry, madam, for a slight mistake in your designation. So let us start with our panel discussion. We are going to do some panel discussion on some of the practical problems that we get every day in our everyday practice. Today we have some eminent panelists with us. All of them are very brilliant in their practice and in their practice of obstetrics and gynecology, including infertility. Start with Professor Nilufar Sultana, Professor, former head of the Department of Obstetrics and Gynecology, Dhaka Medical College. Our second panelist is Professor Jasmine Banu, Professor and Chairperson, Reproductive Endocrinology and Infertility Unit, BSMMU. Our third panelist is Brigadier General Anjumanara Begum, Professor and Head, Armed Forces Medical College. Then comes Dr. Nazneen Ahmed, Associate Professor, Department of Obstetrics and Gynecology, Holy Family Red Crescent Medical College. Then our fifth panelist is Dr. Shakila Ishad, Associate Professor, Reproductive Endocrinology and Infertility Unit, BSMMU. And last but not the least, Dr. Florida Rahman, Associate Professor, Reproductive Endocrinology and Infertility Unit, Dhaka Medical College. So today we have 6 scenarios and we are going to cover mostly all aspects of infertility management, and there will be 6 scenarios which will be actually explained to us by the 6 panelists. So let us start without any further, let me see. Okay. Let's start the share. Okay. So let us start with the first scenario. The first scenario is a young woman, 31 years of age, BMI is 28 kg per meter square, comes with irregular cycle with prolonged bleeding. Now she is having amenorrhea for 2.5 months. She's a banker, she has long office hours, a very sedentary lifestyle. She and her husband are trying for pregnancy for 5 years. She has history of ovulation induction with clomiphene citrate for 6 cycles by a local doctor where there was no facility for follicle monitoring. Her husband's semen analysis is normal. So let us first go to Professor Nilufar Sultana. Madam, you are here? Is Professor Nilufar Sultana
Can you
here?
hear me?
Yes, I can hear you, madam. So, madam, what do you think? What is the diagnosis and how do you want to proceed?
Okay. Thank you, Sabina, for your kind information and introduction of me. So, Assalamu alaikum and very good evening to all of you. This is the last session of today's virtual international scientific conference organized by Fertility Sterility Society of Bangladesh. So we are very much fortunate to have with us all renowned fertility specialists from home and abroad. And also we are learned so many new things from their excellent, brilliant and time demanding presentation. And I am also pleased to be one of the panelists in this prestigious conference. So now I come to my scenario. The lady is 31 years old and her BMI is 28 kg and period is prolonged and irregular, and she is a banker and spent most of the long time in her office. So her husband, they are trying for pregnancy for 5 years and took ovulation induction by clomiphene cited by local doctors without monitoring. And her husband's semen is normal. So the scenario mostly suggestive of the polycystic ovarian syndrome, and maybe she is suffering from anovulation. So first of all, I like to evaluate her properly, as she is obese because she is overweight because her BMI is 28 kg. 28 kg. So I need to evaluate properly regarding the history, whether their conjugal life is happier, whether their intercourse is time demanding, how frequently they meet for intercourse. This is one of the important things, or any problem in their sexual time. So anything we need to evaluate her physical examination, there is anything, hirsutism or acne or something like that. As she is obese, so her BMI is very high, so she need to evaluate endocrinologically and metabolic aspect. So she need to, I advise her to do some blood test and some biological test, and also we need to do laparoscopy as well as hysteroscopy to evaluate properly her condition. And just I need to do her blood sugar to exclude that she is suffering from diabetes mellitus or not, or other endocrine problems such as the serum thyroid stimulating hormone, prolactin, vitamin B12, fasting, insulin level, and also to assess her ovarian reserve, we have to do the serum AMH also. And ultimately, as she is already exposed to ovulation inducing by clomiphene, such as the I hope, although it is without cycle was without monitoring, even then we need it may be due to clomiphene citrate resistance. So after evaluation her endocrine and metabolic aspect, then we need to evaluate her tubal patency and also anything inside the abdominal cavity. That is why we need to do the laparoscopy as well as the hysteroscopy simultaneously. In laparoscopy, we must see whether there is a morphological features of the ovary, whether is enlarged, whether there is a multiple cyst in the ovary or not. And simultaneously, we do the chromoperturbation to see the patency. If there is a multiple cyst in the ovary, then we can do the drilling, as because the fluid which is escapes from the follicles, they may reduce the peripheral androgen. So there may be chance of the spontaneous ovulation. And simultaneously, we can do the hysteroscopy if there is an undiagnosed endometrial polyp or something, if there is any septum or anything. So after this evaluation, we must advise her to reduce the body weight, to change the lifestyle. As because when she reduces the body weight, there is a spontaneous resumption of the abnormality of the hormonal level and the endocrine problem also, and there is a reproductive outcome is also good, and the menstruation may be regular and the ovulation may occur spontaneously. So the reduction of the weight must, we advise her. Then regarding the fertility treatment, we just advise her if the AMH is good, if the every profile, every endocrine finding is good, so hormonal finding is okay, then we will advise her. If the tubes is patent, we'll advise her for the next 3 cycle of ovulation induction by the aromatase inhibitor with close proper monitoring. And if this subsequent 3 cycle is failed, then we will advise her and plan her for the control ovarian stimulation and IUI for 3 cycle. If this 3 cycle fail to achieve the pregnancy, then after counseling, proper counseling, we may advise her for in vitro fertilization. As the all PCOS women may be very much hypersensitive to ovulation induction, but especially this case when the chromophene citrate is maybe resistant, so she may respond very well by the maybe aromatase inhibitor. So this is the way we can improve her fertility. Thank you, Sabina.
Thank you, Madam. Madam, do you think it's better to give ovulation induction with aromatase inhibitor with follicle monitoring before laparoscopy, or should we go to laparoscopy first?
Thank you. I think as she is 31 years, then I suggest that before I can try ovulation induction by laparoscopy. After ovulation induction, after doing laparoscopy, wants to see whether the tube is patent or not, as she is 31 plus.
Okay. Do you want to add metformin, madam?
Yes, sorry, I just forgot. Yes. I like to add metformin here from very beginning when I advise her to reduce the weight, as because metformin doesn't work to reduce the weight, but it is the insulin sensitizer. It may help the internal environment and may sometimes produce the spontaneous regulation of the cycle and also the ovulation. So we can definitely advise the insulin sensitizer like metformin continuously. And sometimes after 3 to 6 months, we must do the renal function test. As if there is a problem in renal function test, we should stop the metformin, as because this may produce the even very rare but the fatal complication like the lactic acidosis may occur.
Thank you, madam. Just starting before the second scenario, I want to add that 2 of our renowned chairpersons are most welcome to give any comment, share any experience in this field. So please, madam, feel free to add anything if you want to. So let us come. Yes, madam.
Good evening. Good evening. Can you hear me?
Yes, madam.
Actually, my all respect and gratitude to everyone, those that participate in this program, and my rapporteur, speaker, and co-chairperson also. I am very pleased to be a part of this scientific program as a chairperson. So this is the scenario. Actually, this is a high BMI and definitely regular cycle. She's a patient of polycystic ovarian syndrome. So we can go for this proper investigation, actually confirmation of the diagnosis. Actually, transvaginal scanning is very much important before going to a laparoscopic surgery to see the follicle, because multiple follicle in TVA scan is helpful. We know to diagnose the PCO. and the endometrium thickness, like as that we can exactly but properly detect by transvaginal scanning. So first thing we go for laparoscopy, histoscopy. I think we can go for this a good transvaginal scanning and the saline sono infusion for these patients for the before going to any invasive procedure. So here I can importance to give in this saline infusion sonography in that point. And okay, we can, because the patient took clomid without any follicle monitoring, so we can go for this. Before we should have to know what doses she got for this ovulation induction. So if it is, we know the dose may be 50 or maybe 100. So we can assess after proper assessing. We advise her to reduce weight. We advise her to use metformin, and we can use endoclomid. And that dose she had taken, it may be 100. We can try for 150. Just 1 to 3 can monitor the follicle. If not a good result, we go for the letrozole then and properly assess, and then can stepwise we can change the ovulation inducing drug, can go for the injectable form, whatever it may be. And there simultaneously the follicle, when follicle is growing good, mature, and we can go for the IUI and subsequent step for going for the fertility. So IUI, and in 4th cycle IUI, then we can think that this IVF procedure. So we can follow the step of that. I don't know, that may be helpful before going to a direct laparoscopy. Or laparoscopy, we can go for the second line treatment, laparoscopy, histoscopy. We have also in our hand. So, so this is my opinion. I don't know. Thank you.
We can go to laparoscopy directly, then ovulation induction, or we can start ovulation induction for a few cycles, then go to laparoscopy. Okay, let us come to the second scenario. Let me see. A 28 years old housewife, para 0, with a history of 1 induced abortion, complains of painful intercourse, heavy menstrual bleeding, and inability to conceive for 4 years. Her menstrual cycle is regular but painful. She has gone to a local doctor where hysterosalpingography has been done, and which shows bilateral tubal block with dilated left fallopian tube. Her husband's semen parameters are normal. Now can I ask Professor Professor Anju Manara to talk about this scenario, how to proceed, what might be the cause, and what can we do. Professor Anju Manara. Are you here, madam? Professor Anju Manara, has she joined? I don't think she's here. So we can actually talk to Professor Brigadier General Hasina Sultana. Oh, madam is here. Okay. Madam, Professor Anju Manara, are you here? Is she here?
Here, but she's not audible.
She's not audible. Should we continue or should we wait?
I think she is going through the headphones. That's making the problem.
Okay. So we can come back to her scenario later on.
আপনি হেডফোনটা খুলে এমনি বলেন।
এখন শোনা যাচ্ছে?
হ্যাঁ হ্যাঁ বলেন।
Respected chairpersons, Brigadier General Hasina Madam and Shamsuna Laki Madam and Tanjim Sabina Chaudhary and all my dear colleagues. Assalamu alaikum and very good evening. Again, we are very lucky that we have attended this panel discussion with so many interesting topics. And without wasting very much time, I wanted to discuss regarding the case. Actually, she is a case of 28 years old housewife having 1 induced abortion. And the history itself indicate that she is having pelvic inflammatory disease, most probably. And she is having painful intercourse, heavy menstrual bleeding, and inability to conceive for 4 years. And her menstrual cycle, though it is regular, but having heavy flow and painful. And hysterosalpingography is bilateral tubal block but it is not mentioned whether it is a fingral block or corneal block, even though I wanted to take it as whatever there is block. And dilated
Fimbrial block, that's why there's a hydrosalpinx.
Yeah, the left fallopian tube block. So there is a left sided hydrosalpinx, and her husband's semen analysis is normal. So this is a case of PID definitely, and with heavy flow, it might be there is some fibers or associated with PID also. Sometimes we get heavy menstrual bleeding followed by less bleeding, scanty bleeding. That is the latter part. So we have to investigate her properly by Pap smear or Via test, and followed by, if required, colposcopy. And endometrial biopsy, I wanted to do endometrial biopsy. We have to see whether she is having chronic endometritis or any tuberculosis, TB, PCR, or if facility is available, we can do gene expert also. And
what do you want to do about the tubal block? How should we proceed with the tubal block?
The tubal block, I don't think we will not be able to manage this tubal block. We cannot open, because if we at all open it, due to her PID, we will not be able to get the good success, because by this time her cilial movement or cilia might have damage. So we can go directly for IVF after giving good antibiotics and investigating her regarding tuberculosis of her endometrium and pelvis also, and her husband's semen also. We can do acid fast bacilli, and if we get all these things there, we can give treatment. Going IVF, we should do the tubal clipping
for laparoscopy to find out whether the tubes are really blocked or not. Or is it necessary to block the tube if you want to go for IVF?
Yeah, this is a very good thing. We can do hysterolaparoscopy before second choice. Like we could go for hysterolaparoscopy, and if we find there is features of any PID or tuberculosis, then we have to give treatment. And one tube is open, or we can make open, but there is success is less. Even though we can try for pregnancy with normal ovulation induction or intrauterine insemination. If she does not conceive, then we can go by IVF.
Okay, thank you, madam. Can I take the remark from Professor Brigadier General Hasina Sultana? Madam, do you have any other comment? You want to manage these patients differently?
Yes. Thank you so much, Dr. Tanjim Sabina Chaudhary, for your excellent moderation. Respected speakers, chairs, panelists, and all the participants, Assalamu alaikum and very good evening to you all. Actually, this session is the last session, and it is a mixed bag session, and so many things we are listening, and we are getting comments from our panelists. First of all, I like to congratulate all the panelists of our session. They are all very learned in their respective fields. And regarding Brigadier Anjuman's scenario, I like to mention one thing. She was talking about tuberculosis. I don't think in this case tuberculosis will come first, because in tuberculosis we know that the endometrium contain the granulomas and the scanty menstruation, not heavy flow. And so painful the menstruation is. Actually, this does not go with tuberculosis. I will suggest the patient to go for HBS and cervical swab culture and sensitivity, and laparoscopy. We can go for laparoscopy also to see how far is the blockage, where is the blockage, and actually both the tubes are blocked or not. We can confirm it, and we can see the additions, how much is the addition in the pelvic cavity. and the ovary conditions of the ovary also. And at best we can go for during laparoscopy, we can go for endometrial biopsy to actually hysteroscopy at the same sitting can be done. We can do polypectomy if she is having polyp because she is having heavy flow, and we can go for endometrial biopsy from the other part. And after that, I like to give her antibiotics for prolonged time, and I have to see the progress. What is the effect of antibiotic on this? I will go for further treatment of the infertility for this patient.
Okay, Madam, I think it's very important to reconfirm the hysterosalpinography finding by laparoscopy.
Yeah.
And also there is a need for tubal clipping because this patient, there's a great chance that she may go into IVF. So hydrosulfings, we have to do something about hydrosulfings before going to IVF.
Yeah.
So it's,
Madam,
yeah.
Definitely we will do screen for PID, chlamydia, and
Yeah.
STD and HIV, all investigation regarding all STDs and any genital urinary infection we will exclude, and we give like maxifloxacin we used to give sometime nowadays for 14 days. Both husband and wife evaluated first, and then definitely we'll go for another laparoscopy. And if there is dilated left fallopian tube and block in the right fallopian tube, if we can do something, we can do, but sometimes it does not work. So if they are very eager for pregnancy, we can go for IUI if one tube is at least open. Then if it does not conceive, then we can go for IVF.
Okay, thank you, Madam.
A question to Dr. Tanjim Sabina. What we will do with the clipping? What help we can do to the patient? How can it act?
Hysterosalpinography has a very large false positive rate of tubal block. We have done a study and it has shown that about 80% of the tubal block that we see on hystero, most of the time one tube may be open. So it's important to reconfirm by laparoscopy whether the tube is open or not. If tube is open, we can go for IUI. But if the tube is irreversibly damaged and blocked, we have to go for IVF. And it's better that we make sure that the hydrosulfings fluid just do not come back to the endometrium during IVF. So it's very important we do cauterization, we can do clipping at the cornual end so that the hydrosulfings, we can drain the hydrosulfings, but it's very important that the hydrosulfings toxic fluid do not come back to the endometrium during the embryo transfer. So if you plan for IVF, it is very important that we counsel both the partner that we may need to cauterize the tube because it's not going to work. Okay, let us
Thank
come
you.
to
Thank you.
Thank you. Next scenario.
CMHA, we used to do cornual end like cannulation by proximal tubal cannulation. I have one patient, she had one ectopic pregnancy and one-sided salpingoforectomy was done, and her one tube was open, was also blocked. So it is in 2015, I did proximal tubal cannulation and she conceived. That baby is now.
Yeah, it actually depends on the tube, the appearance of the tube. If the tube is not damaged, we can open it by cannulation. Yes.
Thank you.
Scenario 3, a young lady, 25 years, a teacher by profession who has a BMI of 21 kg per meter square, comes with a menstrual cycle of 35 to 40 days and infertility for 3 years. She gives history of repeated ovulation induction with letrozole without any satisfactory follicle size. Her serum AMH is done. It reveals that her serum AMH is 0.9 nanogram per ml. Her husband's semen analysis is normal. Professor Jasmine Banu, how do you want to proceed in this patient?
Thank you, Dr. Tanjin Samima, for asking me a good question. And first of all, I would like to thanks the fertility organizer of the Fertility Society to give me opportunity as a panelist. Now I come to the question that young patient is 25 years and the ovulation induction failure and cycle oligomenorrhea and image is 0.9. So this patient, whether first of all we like that is the if the patient is the diminished ovarian reserve or premature ovarian insufficiency. So for diagnosis of the diminished ovarian reserve or the premature ovarian insufficiency, first of all I will do the FSS level and antral follicular count. If the FSS level is more than 10 and FC count is less than 3 in each ovary, then we go for the diminished ovarian reserve. And so we manage accordingly as a patient with the diminished ovarian reserve because the patient husband semen analysis is normal, and if the patient is a diminished ovarian reserve, and we will go for the control ovarian hyperestimulation. We assess the tubal assessment first. After tubal assessment, if the tube is the open, and we will go for the ovulation induction with the gonadotropin and followed by the IUI. And if
gonadotropin you would prefer, Jasminappa, which gonadotropin would you prefer for this patient?
Gonadotropin we first of all prefer for the FSAs, like recombinant FSAs, as there is a MH level is the low and FSS level is the, if the FSS level is the high, and we can give the gonadotropin stimulation, control ovarian hyperstimulation, followed by the, and before I going to this, and we optimize the patient with the dihydroepiandrosterone sulfate, or there are some vitamin, folic acid and micronutrient for optimize the patient and improve the ovarian result, and then go for the ovulation induction with the gonadotropin. If fail, then we go for the IUI after correction, after assessment of the tubal. And if the patient is the POI, that when the AMH level is the more than 25 or the as FC count is less than 1 or 2 and ovarian volume is less than 1, then we go for the control ovarian hyperstimulation with the ART. And before we going to ART, now the experimental process is the platelet dysplasma and stem cell therapy should improve the PY patient and followed by the IVF success. And if it is not possible, and then if the patient is the PY and advice for the donor. But it is possible in our country, that is the, if the patient is the PY diagnosis and we improve the ovarian reserve by the PRP and by the stem cell therapy, and then go for the ART.
So I think we all agree that in this patient we cannot wait. We cannot waste time. So it all depends on what we do, but I think we should do it quickly because our AMH is coming down rather quickly at 25 years, isn't it? So we cannot actually waste time. Most of the time, these patients actually wait for a long time and ultimately come to us with POI. Then there's nothing to do.
And if the FSS level is normal, that is the DOR or the occult POI. If the FSS level, I don't know the her FSS level. If the FSS level is normal and FC count is good, then we go for the ovulation induction with the IUI. And if the FSS level is high and the FC count is low, then we go for the directly for the ART or experimental therapy for the PRP and stem cell therapy, followed by the ART or ovum donation.
Regarding ovulation induction, do you think HMG would be better because it also has LH?
Is the recombinant FSAs and AMH. AMH is HMG is when there is a good follicular count, that is the day 5 and day 7 when the recruitment stage. And after the recruitment stage, there is the day 9 and day 11. And from the day 9, we will go for the HMG because the natural cycle, the HMG, that is the LH is needs from the after the recruitment of the follicle, that is from the day 9. So the day from the beginning of the, we start the FSAs for the recruitment of the good follicle, and then we go for the HMG from the day 9.
So start the ovulation and ovulation FSH, and we are going to add LH from day 9 for
Yes.
proper development of follicle. Thank you very much.
Mature follicle.
Thank you for this elaborate answer. Let us go to the next scenario. A 28 years old housewife married for 3 years comes with a complaints of painful intercourse and inability to conceive for 3 years. She also complains of generalized ill health, loss of appetite, lack of interest in sexual intercourse. She is very thin. Her weight is 19 kg per meter square, which is also coming down in the last 3-4 months. An ultrasound was done and it showed a right-sided adnexal mass about 5 into 3 centimeter. Her husband's parameter of semen are within normal limit. Dr. Nazneen Ahmed. Madam, are you here? Dr. Nazneen Ahmed?
Yes, yes. Thank you, Dr. Tanjim Sabina Chaudhary, for asking me the very fine question. At first, I like to congratulate the Fertility and Sterility Society of Bangladesh for arranging such a fantastic conference, that is virtual conference. And also thanks to the society for selecting me as a panelist in this nice session. Now come to the scenario. This is the patient of 28 years old. She is housewife. She is married for 3 years. She is very thin. That is, her BMI is 19 kg per meter square, and it is coming down from last 3 to 4 months. And actually, she has also generalized ill health, loss of appetite, lack of interest in the sexual intercourse. And also, there is mentioning one thing, that she has the mass, adnexal mass. This is about 5 centimeter into 3 centimeter, and husband's semen parameter is normal. So at first, I like to come to the diagnosis, whether this is due to any psychological problem, anorexia nervosa, or this is due to the genital tuberculosis, or sometimes it may be also due to the malignancy. So at first, I just take the detailed history from the patient and also from her husband and her surroundings, also the relatives, whether she has any psychological upset or not, because she has also lack of interest in the sexual intercourse. So if she has any problem with her regarding her married life or her surroundings, so I have to counsel her regarding her psychological problem. And also if she has, I also suspect that whether she has any genital tuberculosis or not. And in this case, I have to take detailed history, whether she has any evening rise of temperature or not, she has any childhood tuberculosis or not, because sometimes the tuberculosis, lung tuberculosis, from other side, that there may be the genital tuberculosis. So I have to take the detailed history, and then I have to examine the lady in details. And after that, I will do some investigations, some blood investigations, complete blood count, and also the tuberculosis related some investigations. I can do Guinness-Barré test, or also I can do the chest X-ray for her lung status. And if I suspect that this is the genital tuberculosis, then I can also do the menstrual blood for tuberculosis culture. And if it is the tuberculosis, then I can give her anti-tubercular drug for a long time, at least 1 year. And after that, then I will assess her status, whether the genital tuberculosis actually subsides or not. And if it is clear, then I can also test it after about 6 months. And I am not actually forgetting about the ultrasonographic evidence of the mass. It may be due to the tuberculosis, or it may also be due to the malignancy. So I have to exclude the malignancy also. And for this reason, I have to do the some marker, tumor marker, and also get the transvaginal ultrasonography with the Doppler study, whether the mass, the nature of the mass, and also whether there is increased vascularity or not, whether this is suggestive of any malignancy or not. So if it is malignancy, so we will proceed for the treatment of malignancy, towards the treatment of malignancy. So actually my stepwise management will be at first to counsel the patient to take whether this is due to psychological, then towards the tuberculosis, then towards the malignancy. And actually, she's married for 3 years. She's audit. So after that, then I will proceed accordingly.
Appa, she is, we know that the tumor marker for tuberculosis and malignancy often overlap. Like if you do a CA125, we can get raised CA125 in both the cases.
Yes.
So do you want to go for laparoscopy to see what type of cyst it is? Do you want
Yes,
to take
yes,
any biopsy?
of course. We can go also for laparoscopy, because by means of laparoscopy, we also can evaluate the tumor status and also the tubal status and also the peritoneal factors or something else. So by means of a single laparoscopy, we can evaluate her widely. So we should also do a laparoscopy.
Okay, I come back to Dr. Shamsun Nahar Laki. Madam, do you want to do a laparoscopy in this case?
Actually, this is a very nice scenario. If we think that this may be infected case, maybe a tubovarian abscess, maybe a tuberculosis, maybe a chlamydia-related infection leading to this condition, maybe chocolate cyst and pelvic endomyosis is suspicious. So beside this, all investigation, even everything we have want to do, and actually in the TB that we have done in the collection of the menstrual blood and send this blood for the PCR test. That is very helpful, PCR detection of the TB. So beside this, we must go for this laparoscopy definitely, because she is a definitely infertility, and we should have to need appropriate diagnosis of the cases and evaluation of this laparoscopic, and at the same time we can treat the situation confirmed by biopsy. We can treat the condition. If it is a chocolate cyst, we think we can remove, we can do the appropriate measures, either chocolate cystectomy or need to adduce lysis, or at the same time tubal patency. If we suspect it's maybe tubercular, so we can take a biopsy from that area, or any malignancy we can suspicious, we can go for this, or any tubovarian access PID related, we can treat the case in this simultaneously, and we can that time we can make a plan for how can improve her as a fertility status after taking or seeing the laparoscopic view and making the planning for her future fertility. I think so.
Thank you, madam. Let us go to the next scenario. A 21-year-old student comes with her husband for infertility workup. They're married only for 6 months. Her husband is diabetic, has a BMI of 28 kg per meter square. They complain that there is no ejaculation of sperm during intercourse. Dr. Florida Rahman. Madam, are you here? Appa? Dr. Florida?
Thank you very much, Dr. Tanzim Sabina Choudhury, Jaya, for your nice question. I think this patient is not infertile. She has come for preconceptional counseling, but her husband has a problem, that is her failure to ejaculate. Am I right?
Yes.
That is an ejaculation or retrograde ejaculation.
Yes.
That ejaculatory difficulty.
Yes.
There may be defect in early ejaculation, or there may be difficulty in emission, like that, or it may be retrograde ejaculation. So this patient and her husband is also suffering from diabetes mellitus, but what is her glycemic status now? It's not mentioned.
It's not controlled. He is obese and his diabetes is not controlled.
So I have to evaluate the patient's husband. He's my patient. So I will first do physical examination, and I will do necessary investigations of the patient. Among the physical examination, most important is her scrotum volume and whether there is any varicocele or any marks of operation, or whether he took any history which hampers his ejaculation. I will take that. And after that, I will do semen analysis, but probably if it is ejaculatory difficulty, he may not produce any semen. So, and if it is retrograde ejaculation, then I have to give him preparation for collecting semen from that urine and I will advise her for taking sodium for few days for making the urine alkaline. Then I will centrifuge. I will advise for centrifugation of the urine, or urine maybe bladder may be evacuated before masturbation or taking the specimen. Then spermatozoa can be found, and that can be used for either IUI, that can be cultured in a media, thyroid solution or like that, or and then that can be used for either IUI or for IVF. It's the treatment, but if I want to improve his sexual life, then I have to counsel him appropriately. I have to ask him to control diabetes, proper glycemic control, for exercise. I have to give him supportive psychological support. And then there are some pharmacological drugs which may help him, like the alpha agonist like ephedrine, pseudoephedrine, dopamine agonist, selective serotonin receptor uptake inhibitor like dapagliflozin. I can use that, and ultimately, fertility treatment can be successful by IVF, I think.
Yeah, I don't think urinary sperm would be very much successful in IUI. So I think in this patient, if there's a true retrograde ejaculation, the only option may be ART with urinary sperm. Yeah.
Yes.
Thank you, Dr. Florida. Next, the last scenario, a 34 years old doctor, BMI 25, married for 4 years, comes with inability to conceive for 3 years. They have visited several doctors, has history of ovulation induction for a year, with some reports showing good follicular size. Her husband's semen is normal. Laparoscopy was also done recently, showing normal uterus, bilateral patent fallopian tube, and fresh corpus luteum on left ovary at the time of the laparoscopy. Dr. Shakila,
well, thank you. Can you hear me?
Yes, Appa.
Okay. It appears to be a case of unexplained infertility, as it should. There's no ovulation. There's good follicular size on ovulation inductions, and husband semen analysis is normal, and laparoscopy shows bilateral patent tubes. So in unexplained infertility, we say that actually the infertility is not entirely explained by these 3 investigations. There must be some cause, but instead of finding this cause, treating is more beneficial to the patient. Yes. So that's why, without wasting time, we will go for next steps of treatment, fertility treatments. Since she has already had laparoscopy, we will prefer ovarian stimulation with intrauterine insemination for her. Ovarian stimulation will produce multiple follicles, and intrauterine insemination will ensure good quality sperm to come together and increase the chance of pregnancy. And ovarian stimulation with IUI can be done at least 3 times or at maximum 6 times, and according to patient's wish and ability. And if this fails, I will advise the patient to go for IVF. But there are some other factors we have to look for, like ovarian reserve. Since she is 34, before this fertility treatment, I have to optimize her weight because her BMI is 25. And since it is not mentioned over here, but I will also look for any uterine factors like adenomyosis or fibroid, which is common in this age, and also any uterine cavity abnormality before that.
Appa, you want to look for the ovarian reserve. Do you think if this patient comes with low reserve, you want to go straight to IVF?
Yes, if that depends on the reserve, and any fertility treatment also depends on what the patient wants, what the patient can afford. And the ideal is for, in some guidelines, they say that this patient should straight go for IVF, but in our country, we go for IUI before, because most of the patients will not go for IVF.
Yes, true.
even in national in England, they usually prefer IVF since cost is a factor for them. But with our patient, even patients cannot afford IUI, they will want to try ovulation induction. But the success rate is highest for IVF, and it will depend on the ovarian reserve will help us counseling about the probability of success of the treatment. And also we can decide for the ovarian stimulation protocols or that.
Yeah, definitely. Thank you. I would like to ask Professor Brigadier General Hasina. Madam, do you want to add anything to this?
Regarding the fifth case, actually out of 6 cases, I have seen only 1 case. Nowadays, we know that 50% of the males for infertility, 50% responsibility of males 50% and female 50%. But I'm seeing out of the 6 infertile cases, only 1 is having male infertility. Then one thing I like to mention, the panelist has explained very nicely, but would it be a case of absence of vas deferens, congenital block or congenital absence of vas deferens? এটা কি হতে পারে? রেট্রোগ্রেড ইজাকুলেশনের উপর আমরা বেশি এমফেসিস দিয়েছি, আমরা সবাই জানি এটা ব্যাপারটা, বাট এটা কি হতে পারে? এরকম আমাদের কেস আছে, কিন্তু আমাদের মধ্যেই একজনের আছে যে মানে সারা ইয়েতেই হয়নি, স্ক্রোটামে সবকিছু ঠিক আছে, টেস্টিস এভরিথিং ইজ ফাইন, বাট দেয়ার কনজেনিটাল অ্যাবসেন্স অফ ভাস ডিফারেন্স.
Usually if there's congenital, then azoospermia. Usually they come with azoospermia because the fluid is there, but there's no sperm. But in case of complete anejaculation, it's usually retrograde ejaculation we find.
Retrograde only causes retrograde ejaculation.
Maybe or complete anejaculation.
Or any ejaculatory dysfunction.
Yeah, any ejaculatory dysfunction.
Negative for ejaculatory dysfunction.
Yeah.
It's not azoospermia.
Another thing regarding the number 4 scenario, I like to say one thing. Everybody thought about the TO mass due to tuberculosis or chlamydia or other things, but first of all, come in our mind is endometriosis, that is chocolate cyst. It might be, it is a common thing, rather than this TO mass due to tuberculosis and other things also.
But actually the scenario is the patient has ill health, loss of appetite, lack of interest to the sexual interest, BMI is very low. So according to this scenario, our concentration is towards the tuberculosis, but it might be a case of endometriosis also.
Now we get an overlapping picture of tuberculosis, endometriosis, as well as malignancy.
Exactly.
Okay, thank you all the panelists. It has been a great panel discussion because of the spontaneous participation of all the panelists. We discussed almost all
Dr. Tanjeev, about the last case, the unexplained infertility, the panelist has described it very nicely, but one thing, the age should be considered because she's 34 years. We cannot waste time for long time for her, and she's 25, that the upper limit of normal BMI. So we can go for ART or IVF like that because she's already 30.
Madam, here just mentioned the hysteroscopic evaluation is very much important. In my experience, I found a small polyp, just multiple small polyp, just lies in the os. That can be interfered somehow. So hysteroscopy can give some importance regarding hysteroscopic evaluation, not only the laparoscopy, and highlight this point also.
Thank you. Thank you, Mappa. Thank you, everybody. It was a very spontaneous participation of all of you that has made this panel discussion very interesting. We have covered almost all the practical problems that we face every day. So until next conference next year.
Another important in unexplained infertility, যে আপা যে বললো যে hysteroscopic evaluation for the septate uterus, undiagnosed septate uterus is one of the important for unexplained infertility, and hysteroscopic evaluation is the most important. And another important is the double IUI, and double IUI is a treatment for the unexplained infertility, and the chance of success is more in case of the double IUI. The first time, that is the 24 hours after trigger, and then the 48 hours after trigger. Is the success is increased.
For the added
Yes.
information. So I now give my microphone to our rapporteur, Dr. Rakhi. She can wrap up the session. Thank you everybody for your spontaneous participation.
Thank you very much.
I like to say something, Tanjim.
Yes.
Just only 1 or 2 minutes. Actually, it's a very, first of all, I would like to thank Professor Maruf Siddiqui and the scientific committee of FSSB to give me the opportunity to chair a session of such a prestigious international conference. My sincere thanks to organizers of the conference who have generated a lot of interest amongst all of the gynecologists of Bangladesh, because most of the time we come across the infertile cases, all the general OBGYN, especially all of we come across the infertility cases. So we have gathered a lot of knowledge from this 2 days conference. I congratulate them for their relentless effort to make the conference successful. Personally, I can say I listened to almost all the speakers for the last 2 days. I felt I am sitting in a classroom. আসলে বাংলায় বলতে গেলে মন্ত্রমুগ্ধ হয়ে শুনেছি আসলে সব সেশনগুলোই সত্যি খুবই সুন্দর. I have a humble submission to the authority as well as our OGSB, whether we can arrange virtual conference rather physical presence conference next time also, because we know we have seen that the virtual conference has got few advantages over the physical presence conference, like participation is more, I think so, easier to participate, less expensive, less tiring, and less time consuming. So actually, and last of all, I like to say thank all the panelists. They are very learned and explain their opinion very nicely, very nicely. They have explained, because we have no more things to add or comment. So I must thank all of you, and
thank you, Appa. Thank you. Now I'm transferring the microphone directly to Professor Roshan.
And one thing, last of all, I like to say one thing from this conference. What I understood, that for the treatment of infertility, nothing should be generalized. Everything should be individualized. On the contrary, I came to know there should be guideline and specific protocol for the treatment of individual patients. I think both the opinions are correct. Actually, both the opinions are correct. Okay, thank you so much, Dr. Tanjim Sabina Chaudhary, the rapporteur, Rakhi Devi, and all the panelists, Dr. Jasmine, Dr. Anjuman, Dr. Nilufar Sultana, and Nazneen Ahmed, Shakila, Ishrat, and Florida. Thank you so much.
Thank you so much. Thank you so much, everybody.
Thank you.
Roshan, madam, you can start. Madam, please start.
Thank you, শোনা যাচ্ছে?
জি ম্যাডাম,
শোনা যায়?
জি ম্যাডাম, শোনা যাচ্ছে।
Thank you everybody for your excellent participation. It gives me an immense pleasure to thank, after 2 days, excellent, innovative, informative, knowledgeable, and sometimes heart-touching thoughts. In one word, it was wonderful. I would like to take this opportunity to thank all our foreign delegates who, due to their time constraint, they participate in our program and maintain their schedule. And thanks to all our registered 400 members. It shows that we own the COVID and we need to know the update knowledge. Thanks to the participants, because without their participation, it will not be possible to make it successful. Thanks and hats off to all the young rapporteur and the moderator. They had excellent day they have performed. Thanks to all the chairperson who took the trouble to make it successful. And my heartfelt thanks to the Nubista, especially for their innovative works. I'm so moved, especially for the Farjana. Special thanks to you. Lastly, but not the least, our beloved Professor Maruf, who took all the trouble. বাংলায় বলি যে বকা খাইছে কত কিছু করছে তারপরেও সে এত কষ্ট করে এমন সাকসেসফুল একটা কাজ করে গেল আমি অসম্ভব তাকে আমার প্রাণ ঢালা শুভেচ্ছা and my regards to all the organizers, I mean, those who are participating from all corners of the world. Thanks to especially আমি এখনো বলি যে এখনো সবাই মনে হচ্ছে আমি বোধহয় আরো 1 ঘন্টা সময় দিলে তারা 1 ঘন্টায় কথা বলতে পারবে এবং এত নলেজ এক্সচেঞ্জ করতে পারে সবাই এইটা আমি কালকেও বিমুগ্ধ হয়ে শুনলাম যে আসলে সবাই সবার কথা বলতে চায় না যায় এবং আমি খুব মুগ্ধ হয়ে বলি যে আসলে FSSB কে আরো স্ট্রঙ্গার করো এবং এটা আমরা 2001 সালে তৈরি করি
নেট প্রবলেম হয়েছে কেটে গেল ম্যাডাম
আনমিউট করে নেন
সরি আমি চাই যে আরো স্ট্রঙ্গার হোক এবং আমি জানি যারা নিউ লিডারশিপ এটা আরো বেশি ভালো হবে সবাইকে অসংখ্য ধন্যবাদ মারুফকে স্পেশালি আরো অনেক ধন্যবাদ অনেক বকা দিয়েছি কিছু মনে করো না কিন্তু হোল মানে ক্রেডিট মানে আমি বলি যে আসলে একা এতটা কষ্ট করা মানে আমি কি বলবো ওর মাথার পিছনে সূর্য করোনা লাগিয়ে রাখছে কিন্তু মনে হয় যেন লাল সূর্য জল করতেছে মারুফের মাথার পিছনে সূর্যের মতো আলোকিত হোক সবকিছু তোমার কাছে করোনাকে তুমি জয় করেছো
চুল পড়ে গেছে তো এই কারণে সাদা ব্যাকগ্রাউন্ডটা লাগাই
করোনাকে আমরা জয় করেছি এটা মানে প্রুফ করে যে করোনাকে
আসলে ডক্টর মারুফের অনেক খুবই
হাসিনা যেটা বললো যে এত আমার কাছে অবাক লাগছে রিপোর্টাররা এই যে প্রত্যেককে টেলিফোন করে বলা আপনার এতটা সময় আছে আপনার এত সময় আছে আপনাকে এটা করতে হবে ওইটা করতে হবে প্রত্যেকে এত এক্সিলেন্ট বলছে এটা আমি মনে করি যে নিউ লিডারশিপ আমি একেবারে হ্যাটস অফ টু অল দ্য নিউ লিডারশিপ আমি আমার প্রাণ ঢালা অভিনন্দন দোয়া যে নিশ্চয়ই ফার্টিলিটি সোসাইটি অনেক ভালো লিডারশিপ নিয়ে এগিয়ে আসতে পারবে অসংখ্য ধন্যবাদ সবাইকে
থ্যাংক ইউ ম্যাডাম
থ্যাংক ইউ যদিও ছাড়তে ইচ্ছা করতেছে না অনেক কথা বলার ইচ্ছা থাকে কিন্তু আসলে সবাই সব কাজ
ম্যাডাম আপনি আমাদের জন্য দোয়া করবেন আসসালামু আলাইকুম ম্যাডাম
ম্যাডাম
Excellent session with you. Thank
ভালো
you.
করো খুব ভালো হচ্ছে
Thank you. Wonderful
Thank
session.
you. Bye bye. Good night.
Thank you.
আমার হাজবেন্ড বলে যে আমি আরবিট্রেশন করলাম আধা ঘন্টা লাগলো না
মারুফ অনেক কষ্ট করছে মারুফকে স্পেশালি থ্যাঙ্কস
আমার হাজবেন্ড সারাদিন বসে থাকতে দেখে বলে তোমরা এত লম্বা বড় কি মিটিং করো বোঝানো যায় না
মারুফ অনেক সুন্দর হয়েছে থ্যাংক ইউ সো মাচ
থ্যাংক ইউ ম্যাডাম
থ্যাংক ইউ আপা এখন 2 দিন পর আমার বউ আমাকে বাসায় ঢুকতে দেয় কিনা বুঝতে পারছি না দেখি